Good morning, everybody. Welcome to the 10th Annual Women's Heart Symposium. I'm Nicole Weinberg.
I'm Alex LaJoy. I'm Christiane Scheffler.
And you'll hear from Dr. Serena Vanderzee in a little bit. We represent the Women's Heart Center at Pacific Heart Institute and the Have a Heart, Save a Heart charity. We are so grateful to be spending our 10th anniversary with you. Today's meeting includes not only educational information from our top medical professionals and leaders, but also community involvement from women-owned businesses. We're excited to help create a community which empowers you to live your best, healthiest, most heart-strong life. We feel so lucky to have the amazing support of our community. We need to thank Providence St. John's Health Center, Pacific Heart Institute, and the incredible staff, as well as the Women's Heart Center at Pacific Heart Institute for the support over the years. We also greatly appreciate the St. John's Foundation and everything that they do, especially from Markina and Gail. We also have to thank our board members, as well as our think tank, Sheil, Irene, Libby, Meryl, and Lisa. We couldn't do it without you. So Dr. Itchhaporia is the immediate past president to the American College of Cardiology and an interventional cardiologist. She is the Eric and Sheila Sampson Endowed Chair in Cardiology, Cardiovascular Health, Director of Disease Management at Hoag Heart and Vascular Institute, and Associate Professor at the University of California, Irvine School of Medicine. She is a champion of preventative health as well as leadership for young women. Please help me welcome Dr. Dipti Itchhaporia.
Good morning. I want to thank all these wonderful women cardiologists, the power of women, and all of the staff that organized this. So it's such a pleasure to be here, and really I can't believe all the women that come out for heart events now. And you know, we thought that when we first started the Go Red for Women campaign that we were going to get all of these women were interested, and then we sort of saw the data show that there were less and less women sort of participating in understanding that women and heart disease was an important issue. So it's nice to see that we're sort of re-energizing that effort. So I'm going to be talking to you about, I don't see anything on this comfort monitor, by the way. So I'm going to be talking about women in cardiology, the next frontier. I don't really have any disclosures for this talk. But there's a book called The Invisible Women, and it says the truth is that around the world, women continue to be disadvantaged by a working culture that is based on the ideologic belief that male needs are universal. Don't you think that's true? That is exactly what happens. We get the medicines that were tested on men. We get beliefs that are for men, but then we have to fit into that. So what I want to do today is things that I want you to ponder from today's talk. What are the statistics for women in cardiology in terms of general cardiology and subspecialty within cardiology? Why do women choose cardiology or any other subspecialty? And what are the barriers, whether they're perceived or real, for a career in cardiology? And then what are the efforts that have been made by the American College of Cardiology? And then what is our role, each of us in this room, from an institutional perspective and from a personal perspective? So why so few women cardiologists? So although about almost 43% of internal medicine residents are now women, they account for only about 21.5% of general cardiology fellows. So there's quite a drop-off. About 10% of these are interventional fellows and 13.7% choose electrophysiology. So certainly, you're not surprised by this data because the procedural specialties are not something that women are attracted to, and I'll talk to you about why that is. So if you look, medical school is about 50% women, and already now it's more than 50% women. And then almost 50% go into internal medicine, although it's a little less. And then if you see how many fellows in training in terms of cardiology, there's that huge drop-off, and then a drop-off in general cardiology and procedural subspecialties. So I want you to see what that jump is like. And so what about subspecialties? So between 1991 and 2016, the percentage of women in internal medicine residencies increased, as you would expect, because there are more women going into medicine in general. But the percentage of women in subspecialty fellowship decreased. Now, why is that? That means they went into internal medicine, but they didn't do further training to do subspecialty training. And if you look at data from 9 subspecialties, women represented, as I mentioned, almost 21% of cardiovascular fellows, but the lowest representation in 9 subspecialties. If you look at these subspecialties, there weren't that many women in cardiology. But they're really represented in some other specialties. Geriatric medicine, almost 77% of women choose geriatric medicine. And then compared to other specialties, if you look at pediatrics, it's about 64% of women go into pediatrics. What about OBGYN? And I would have thought this would have been higher, but it was 59%. And then child and adolescent psychiatry, 54%, and neonatal, perinatal medicine, about 53%. So, and then women, what about other specialties outside of medicine? Well, if you look at urology, for example, only 10% of women choose to go into urology. Although I will tell you that I read yesterday that they had, at Stanford, this was on Twitter, the first all-female urology fellowship class, which is pretty amazing, right? And then cardiology, I mentioned 12%. Surgical specialties, I will tell you, and I'll show you data later, that general surgery made a real push to try to get women involved, and they've made some strides. So they've come up to 22%, and orthopedic surgery is still only about 6%. So I want you to keep that in mind, and I also want you to think about what is the income levels in all of these specialties. When I was a medical student and I did internal medicine, we had a husband and wife internal medicine team, and they invited all of the students for dinner. And we sort of broke off after dinner, and of course, you know, as a student, you love a free meal and at somebody's home. And it's true. And so we went, and I was sitting, we sort of broke off at a certain point. A small group was with him, and another group was with her. I happened to be with him. And he said something that years later has resonated with me. And he said, if you look at historical data, whenever there are more women that influx into any profession, you can almost correlate it with the income levels going down. And so when you think about medicine, as the number of women have gone up, the amount of remuneration has gone down too. So again, this is the same thing. When you look at medical school graduates, you can see that drop off. And this is 2018 data. I had shown you 2015 data. So you can see that the trend has kind of continued. And then that talent gap, right? So if you look at interventional electrophysiology and compare it to other specialties, just to put that into perspective, if you like to look at things visually, you'll see that middle cardiology, the brown bars, versus urology, thoracic surgery, neurosurgery, orthopedic surgery. So a huge difference. And the pipeline, if you look at men versus women, right? General cardiology, 78% men and 21% women. If you look at interventional, I mentioned that, electrophysiology. What about heart failure? Heart failure seems to be something that attracts women, so you definitely see a higher percentage, 27%. And then we have whether they're underrepresented versus white, and if that makes a difference, because I know with the efforts with diversity and inclusion, there's been a push to have underrepresented groups be in there. Why? Because simply put, people really want to go see somebody that they can relate to, somebody that kind of looks like them. And so the idea that we have health disparities in this country, some of that is based on the lack of trust, and sometimes they want to go to somebody that looks like them. So this is general surgery, and I think this is very interesting. So if you look at male cardiologists, which is the very top line, and then you look at the broken line right below that, that's male general surgeons. So look at the male general surgeons, the numbers are coming down. The line, the yellow, the third line is female general surgeons, so you can see that steeply going up. And female cardiology, the curve is not as high, although we are making some progress, and we anticipate that will continue. And even, as I mentioned, fewer female interventional cardiologists. And if you look at even broken down, there's advanced imaging, congenital cardiology. Interventional cardiology does not seem to attract women, although that is also something that we've made strides. I had mentioned to you about 10%, and I want you to look at that bar now, because this is data from 2019, and it's about almost up to 17%. So we have made some progress there. So throughout the world, there's underrepresentation of women in interventional cardiologists, and I can say that being an interventional cardiologist and having gone to a lot of countries and being in the cath lab with some of them, you don't see very many women. And what's discouraging is that if you look at the United States, only about 5% of women are practicing as interventional cardiologists. And so in spite of the efforts of the US professional societies, these numbers have really made some mild progress, but we still think it's a leaky pipeline. And so what makes somebody choose interventional cardiology or cardiology in general? Well, first of all, what is a specialty like, you know? They think about that. Is there positive mentorship? That seems to be a really important effort. If somebody encourages you to do that. So what happened to me when I was a cardiology fellow, one of my attendings, I was in Washington, D.C. at Georgetown. One of my attendings said, I want to take you out to lunch. He took me to the French embassy. All the other fellows were jealous. And the main reason was that he said that I was very talented in the cath lab, and he really wanted me to consider a career in interventional cardiology. And to this day, that stays with me. And so positive mentorship helps. Expertise, so, you know, depending on the fact that they want to learn more, and if they have that prestige, that's not as important, but certainly on that list. But that mentorship piece I thought was very important. And then why are some women not choosing cardiology? Well, there's the occupational radiation exposure and the perceived radiation risk. You know, what if I want to get pregnant and I'm in the cath lab? What happens? What about the fact that there's impairments to family planning? How will I be able to have my baby and still be working as an interventional cardiologist? So is there some discrimination based on the fact that I want to, you know, parent? What about the work-life balance? Boy, they get called all the time. It's 24/7. So challenge it. And how am I going to be the wife that I want to be? How am I going to be the mother that I want to be? How am I going to be the daughter that I want to be? And then there are certainly issues of sexual harassment, although I think in cardiology we've made certainly a lot of strides. I was at the Society of Thoracic Surgery meeting 2 weeks ago, and I was with a colleague of mine, and she and I have been friends since high school, and she's a cardiac surgeon, and she was telling me some stories that were just incredibly appalling. So, you know, there is these issues of misconduct that occur, and then lack of professional advancement, and I'll show you some data on that. Women think they cannot advance the way that a man advances. But that's changing also. And then what about disparities in compensation? My first year in practice, true story, one of the guys that I worked with said, well, it doesn't really matter what you make because your husband works, right? He's a physician, right? What does that have to do with it? And so, you know, and that's a true story. That seems like such a weird thing to say or so archaic. And what about these external and internal barriers? Well, so I mentioned to you lifestyle issues, right? When you wear lead, you get back pain, neck pain, and you know the lead weighs sometimes 715. Now, the things that they've done is they've got xenolite, so the weight has come down on the lead, so that makes it easier. We also have robotic PCI, which is one of the things that I do, so you can be stepped away from the patient so the radiation exposure goes down. And also the systems have been much better in terms of radiation protection. What about the lack of guidance? How do you balance this? So when you have that issue, you know, you need to talk to somebody. Hey, you know, if Nicole calls me and says, you know, I'm trying to do this. Is this possible? And you have another woman that says, no, this is possible. I've done it. So they want to know some guidance there. What about lack of confidence? You know, when you're unsure, when you first come out in practice and you need to act. I remember asking one of the guys that I worked with, and he told me what to do. And I said to him, I said, you know what? I don't need you to tell me what to do. I want to discuss this with you. I don't need you to be the father. I have a great father. I need you to be a colleague. And that's the difference. And so sometimes we get, you know, professional discouragement or rejection. And then what about the family duties? My husband is an incredible partner. He does a lot of things. And so that is one of the things you need to have shared responsibility with a partner. What about hindered ability to travel for professional advancement? I was at Washington University this week to do cardiology grand rounds, and a colleague of mine was there, and his wife is a cardiologist. And he came to dinner the night before when I arrived. And then when I saw her the next morning at Grand Round, she said, yeah, I couldn't come because I had the kids. And it was interesting because I remember going back to the hotel room and thinking, I wonder why he didn't let his wife come to the dinner instead, because I had just seen him earlier in the week for a board meeting. But again, you know, professional advancement sometimes is hindered for women. And then what about the negative impact on the parenting and family? And does that affect, because you can't take on projects? You may not be able to prove yourself. And does that affect professional advancement? And then what about the opportunity cost? And so, you know, I think if you work that much, what does that take away from your family? And does that make you not have the advancement? So I think all of those things. So the American College of Cardiology, which is ACC, had a professional life survey, And in 2016, so it's a little bit older data now, but women were more likely to practice an academic medicine because they felt there was more protection, 32% versus 23%. More likely to be non-invasive cardiologists. More of them were likely to be single, less likely to have children. And then if in the report, they were more likely to experience discrimination. But what about academic ranks? In 2013, 21% were full professors. And I did get my full professorship at UCI recently, and that's because of the fact that I was president. And then 15% became department chairs, 16% deans, and then they were more likely to do a clinical track versus a research track. 2014, you know, again, when you think about faculty appointments, only 16.5% of the faculty appointments were women. And then, like I said, only a small percentage were full professors. So although an equal number of men and women serve as instructors in the academic field, women are less likely to reach those top academic positions. And when you look at cardiology and infectious disease, those are the only two internal medicine specialties in which women have significantly lower odds of full professorship than men. Kind of interesting. So academic ranks, prestigious administrative titles and salaries are significantly lower despite adjustment for publications, prestige of journal, research funding, and clinical productivity. Take that in. Wow. I remember when I first saw that data. This is, you know, data that Cindy Grinds and had published, and I thought that was really interesting. So again, this is something that's being talked about very openly, so I would expect that we would see some changes. I mentioned to you that women don't get married. 71% of women cardiologists are married compared to 90% of men. 63% of the women have children compared to 88% of men. When you think about publications, you know, they had less publications. Again, that's also changing. Almost 9.1% of faculty have NIH grants, but 6.8% were women and 10.3% were men, so out of that pool. So again, we seem to be a little bit lagging in some of these things. What about the lives of cardiology? Now, I know this is hard to see, but this is 2 decades of change. This was published in 2017, but what they did is over 2 decades, women were more likely to experience gender discriminations, particularly affecting relationships and family planning. So, and this is a comparison of both men and women, and what you saw is that sort of difference, particularly striking when it came to discrimination, and that's on the left side, experience discrimination, and the red is the top, women, and blue is in men. So we see a difference there. What about compensation? We talked about this briefly, but full-time, women tended to work less full-time than men. On-call responsibilities, they tended to take a little bit less call. There were more women that did not take call, although again, this is all changing because the younger generation, both men and women want time off. They want maternity and paternity leave and all of that. And then in this, again, this is 2015, so I would guarantee that those RVU numbers are certainly coming up and being more equal. A JACC study showed that there was a substantial salary difference between men and women practicing cardiology, as well as difference in job activities. And so, you know, we know that there has been some change, and I would say that if you look over a 35-year career, that's anywhere from $1 million to $6.3 million earning gap over a 35-year career. That's pretty big. Yeah. And you know, it's interesting. It's not that they don't want to pay us, but when the negotiating table, you just don't ask for it. Women don't ask for it. We're willing to take what they offer us rather than see what we can get. Yesterday, Dr. Wright had a lovely dinner at his house, and Dr. Noelle Mary Verse was there, and she said that there is a group that helps women in academic medicine, and it's called ELAM. And she said one of the things that they teach you is that when you go up to a hotel room and you're at the counter, you said, "I'd like the penthouse, and I'd like to be upgraded to that." And she says the ability to be able to ask for more than you can potentially even get is the chutzpah that you need to be able to get what you want at the negotiating table. And I think that's a really good pay. So, but again, there are many reasons for the pay differences, right? It depends on the specialty choice. There are certain choices. If we choose lower paid specialties, then we're going to get paid lower. And then differences in productivity, obviously, hours, willingness to change institutions. Sometimes women are not willing to change institutions, whereas men will do that to continue to go up. What about differences in rank and leadership? There may be some biased processes for determining rewards. And then again, even if you account for all of these factors, there still is a substantial and unexplained gender difference that remains, and I think we need to really look at those. What about in values and behaviors? Well, women are more likely to sacrifice pay for unobserved job characteristics such as flexibilities. Fathers wish to earn more to support their families. Look at the difference. I have a family, and I think I need to work less to support them, so I'm okay if you pay me less. And a man will say, I have a family, so I need to be paid more because I got to take care of them. Just think about the thinking. So I think it's the messaging. And like I said, women just don't ask, and I think that's the difference. But I do think that there are some recommendations. This was an article in 2017 that said, if in terms of family planning, what are some things that women can do? So in terms of preconception, recognize the importance of pregnancy, parental leave, all of that. Ask questions about radiation safety. Ask who the radiation safety officer is. Make sure that you ask for the leave that you get. And really try to look for a workplace that is supportive of people that have families. Look at who else has families in that group or in a work situation. So this is, again, a lot of wide variety in a maternity leave. Many women experience likely violations of Family and Medical Leave Act. And this has a serious impact, obviously, on professional and personal lives, and, of course, making it attractive. So we need to change that so that it becomes more attractive. I think I've mentioned this before, so we don't really need to go into that again. I talked about the writing committees for major publications. Women represented about 18% in the current and 10% in previous guideline committees. And they were chair or vice chair of 50% currently and 20% of prior versions. So see how much progress we've made. We're trying to get diversity and inclusion in all of that. And so I do think that we have a role to encourage a career in cardiology. So if you do, what I mentioned was the role of female role models. So I think it's important that we model for women. And I think that that's really an important, is to have mentorship, to look for mentorship. And remember, mentors can be your patients. I have a lot of men that are my patients that have been mentors. They're highly successful men that will say, hey, this is what I say. And in mentorship is not one mentor. You can have multiple mentors that can give you some suggestions. And they don't have to be somebody you talk to every day, but you could call them up. I have a mentor that's an orthopedic surgeon that I met when I was a medical student, and I still call him every so often and say, what do you think about this, Michael? And he still follows my career because he's known me since I was a medical student. So I think that concurrent advances and meaningful dialogues on equal pay and supporting pregnancy, early parenthood during training are important steps in a positive direction. This is from Dr. Roxana Moran. I know she was a guest at this. And I think having women at the table to energize other women to join the discussion and rally for our collective cause is really the key message. So I would say that we need to model. I think we need to increase mentorship opportunities for women. And I think that women tend to choose same-sex mentors, but as I said, a mentor can be found in a man or a woman. And I actually think that's a really good thing. So I'll give you an example. I used to walk in the morning with a woman that's a gastroenterologist. My husband is a gastroenterologist. He introduced me to her. She would run something by me, so I had an issue. I asked her, and she thought exactly what I thought. The analysis was the same. I come home that morning, I tell my husband, and he has a completely different analysis. I was like, wow. So I go to work, and I'm talking to one of my male colleagues, and I tell him, and it was like he had talked to my husband. He had the same answer. So I think it's important to get that other perspective. Mentoring is important. I do a lot of mentoring. These are two of my mentees that I've had. And even I have I mentee some of people from abroad, so globally, people that have reached out. That's one of my mentors from China, and it's amazing. These women in China, I did a program where I got to mentor 3 women after a competition, and they all said the same things to me. They said, well, my husband expects me to not work because, when I have a baby, and she said, I didn't do all this training not to, and I thought, wow, you wouldn't know that you were talking to somebody from China, because it's the same issues no matter where you are in the world. So mentoring programs, I think that if they're allowed, then they can figure out how to get into that old boys network, so to speak. Many women learn to play games that we didn't learn in childhood. You especially learn negotiation techniques. And, and I think that we need to continue to nurture that. And then remember, diversity is good, so it's nice to have women, but diversity is just being invited to the party, but inclusion is really being asked to dance, right? And so we don't want just diversity, we want inclusion. We want to be included in the party at the table. And so this was a paper that came out in 2020 that said, what can we do to encourage women to go into, and they said to advance opportunities for women, there's skill development, and I think all women, if they're interested in going up, should work on skill development, leadership and sponsorship, really look for leadership training. Networking, this is a great opportunity, network. And then, like, as I mentioned, mentorship. And then we need to look at our professional organizations for advocacy in regards to parental leave, pregnancy. How do you re-entry into training if you took time off? Fellowship recruitment, community service, all of those things. So I think we have to make our voice heard. You have to build a support network. You have to acquaint yourself with the available resources and really embrace multitasking, because it does take that. And I think we need to demand institutional change, but not in a bad way. Just be at the table and say, well, what about this? Did you think? And a lot of times it's not that they're terrible people. They just didn't think about that, because now it's a different perspective. And so I think institutions should have targeted interventions to support gender equity and the success of really a huge portion of the medical workforce. If you think about medical school being over 50%, if you don't get the women at the table, we're going to have a workforce issue. And so what has the American College of Cardiology done? Well, they developed the Women in Cardiology member group, which was in 2005, so that was really far-reaching. Right now, actually, we have almost 2,000 members in that section, and that's both U.S. and international chapters. And then there's a couple of leadership programs that I think are important. Clinical trial research program, upping your game, teaching women how to be a clinical researcher. And then Sandra Lewis, who is a cardiologist up in Oregon, and she just got on the board of trustees, and she started a mid-career leadership. She said that she was busy with her children, and so she said she wanted to have something for mid-career women, because if they miss the boat in early, doesn't mean they're not interested in this stuff. They may have a different timeline than a man, and so she started this mid-career leadership program. And then, of course, the colleges worked on the pipeline. When I was president this past year, it was 70 years. I was the 70th president, but I was the 5th woman president. And then Athena Pappas, who's there, was the president the year before me. And that was the first time there was a woman followed another woman. And I remember when somebody said they wanted to nominate me, and I had a colleague say, oh, no, they're never going to take another woman. And I said, we had 70 years of man after man, but you can't have 2 women? And so I know that was something that the college celebrating women's contributions to cardiology. And they actually there's a Women's History Month, and they talk about all the achievement of women cardiologists. And then these were the women that have been president in the college, and they did a nice piece on that. Suzanne Noble is the only one that's not alive. Pam Douglas, Minna Walsh, Athena Pappas, and I know Athena was here, I think, the last year, and then myself. But of course, Athena and I got COVID presidency, so we weren't able to go on the road. So we had to do our ceremony in the Hart House, and that's where we got those pictures taken. And the one I'm more particularly proud of is the Times Square picture. And so that was something to celebrate, and I have that in my waiting room, and the patients go, really, you were on Times Square? And the funniest thing was that the patient happened to be on Times Square the moment that was up. And he said he looked up, and he was with his son, and he said, oh my God, that's my cardiologist. And so I think we do have to really acknowledge the growing impact of women in cardiology, and there are so many spectacular women and across the world that are reaching leadership positions, and I think we need to continue to celebrate that. So I would say in conclusion, more women are going into medicine, but less are choosing subspecialty care. You know the data now. Women in cardiology has really come a long way. You know what they say, you've come a long way, baby. I was in the Virginia Slims tournament as a ball girl, but boy, we still have a long way to go. So, and that's okay. But we all have roles to play to support women in medicine. And I highlight that, even though I'm talking about cardiology. Like I said, if 50% of women are going into medicine, it's our job to support those women to choose the careers throughout medicine that will then help our health in the long run. And I think that COVID taught us how important health is. And we can't do health without our clinicians, our nurses, and our physicians. And so women in cardiology. And I think the only way forward is to help a woman helping another woman, a man helping another woman, and the only way is forward is together. So I'm going to stop here, and I'll be happy to. I know that we can't do questions right now. We're going to do it in the panel discussion. But thank you so much for your attention.
Okay. Next, we'd like to bring up Dr. Janet Way. She is the California American College of Cardiology Women in Cardiology Chair, Treasurer, and Southern California Governor-elect. As a member and a leader in the world of cardiology, she brings a strength to our meeting today. Please help me welcome Dr. Way.
Hi, it's such a pleasure to be here today on behalf of the California American College of Cardiology, and I'd really like to thank Dr. Itchhaporia for being such an inspiring leader for all women and all men in cardiovascular disease. The American College of Cardiology really is our professional home for cardiologists, surgeons, cardiovascular team members, and we really want to express just how much we admire this program. Congratulations on 10 years of a fantastic series of wonderful talks highlighting conditions that are important to women from a cardiovascular standpoint. So congratulations, and we really express that. We just support all cardiovascular team members who are interested in advancing the American College of Cardiology's focuses of education, of advocacy, of professional development. And I was actually a resident when Dr. Itchhaporia had an ACC Women in Cardiology dinner many, many years ago, and similar to all cardiologists here are all women in professional careers. We look to people who are before us to guide us in how we can improve our professional careers and our personal careers as well. I'd like to just remind all ACC members here that please look out to the California ACC website to see how our chapter is helping us with our various aspects. The political action campaign has been very focused on how we can improve our work, and we've been mitigating disastrous Medicare cuts thanks to Dr. Wright, who will be speaking in a moment, engaging lawmakers in long-term reform discussions in Congress, decreasing administrative burdens by streamlining prior authorizations through the Improving Seniors Timely Access to Care Act, as well as allowing the telehealth program, which we have been able to benefit from during the pandemic, be extended for at least another year. So I'd like to now just kind of end my welcome. Again, congratulations to the fantastic leaders here today.
Next up, we have Dr. Richard Wright, who individually recruited at least half of the women in our practice as well. This meeting would not be the same without Dr. Wright's lecture. Every year, he brings us the latest and the greatest in terms of heart disease awareness, whether he's teaching us about new research protocols for our patients or what new medications are coming down the pipeline. His talks are some of the most memorable. He has always been a supporter of our women's heart disease mission, and our meeting would not be the same without him. Without further ado, please give a warm welcome to Dr. Wright.
Well, thanks, Alex. One line really struck me from Dr. Itchhaporia's talk, that she was a ball girl at the Virginia Slims tennis tournament. Now, think about that, a cigarette company sponsoring a tennis tournament. That shows you how far we've come. When I was invited to give this talk today, I was given the liberty of talking about anything I want to. So we could talk about pharmacology, but I decided to kind of go out of the normal realm of what a speaker would talk about. And we're going to look down where artificial intelligence is going to play a role. And we're going to use that just by using voice technology. And this is something that's been creeping up throughout societies we'll talk about, but it's relatively new in the realm of cardiology, that how can your voice help your caregivers render care for your cardiology conditions. So that's why I entitled it One Voice, One Heart, and I will show you that there are really compelling data about how analysis of your voice using the power of computers will make a difference, I'll guarantee you, in how we deliver care. These are my disclosures. None of these are relevant to the subject this morning. So let's talk about the voice. So here, modern technology meets the stethoscope. The stethoscope was invented in 1816. It was not invented as a means to better hear the heart. It was invented because of social constraints. It wasn't considered proper for a physician to put, at that time, his, not her, his ear on the chest of a woman to hear her heart. So René Laennec, who was a Frenchman, decided to distance himself from his patients, and in so doing invented the stethoscope. At that time, it was a wooden hollow tube, basically, and then eventually became the modern stethoscope that really has not changed in 100 years. What did change was on June 29th, 2007, when the iPhone was introduced. And prior to that time, we all had, or many of us had PDAs, right, personal digital assistants. But contained within the smartphone depicted here is a computer that, if you look back in computing times, the computing power in your pocket was greater than all of the computing power at NASA when NASA put a man on the moon, right? So it's quite unbelievable that there is the processing power in your pocket that exceeded a mainframe computer back in the 1960s. We have not yet harnessed that in cardiology, so I'm going to show you how we might be able to do so. Voice signal analysis, sorry about that, this is black, but you use voice signal analysis every day. If you have one of these personal things at home where you say, Alexa or Siri or Hi Google, smartphones, all sorts of things, when you telephone an airline and they ask you to go through that telephone tree, so how can we use that in medicine? Well, the generation of voice, most of us think about just the voice box, right? The larynx, where the vocal cords are. There's a nerve that supplies those vocal cords, and the initial, and I'll go a little bit into the history here, the initial iterations of medicine looking at the voice as an indicator of health really focused on that nerve called the recurrent laryngeal nerve. Because if that nerve is not functioning, then your vocal cords will not work and you will be hoarse. Right? So let's look at how the generation of voice occurs. It turns out it's way more complicated than you may think. I mean, we just take voice from the time we turned one and to the rest of our lives. We sort of don't think about the voice. But the voice occurs through many different ways. You have to innervate these various things. So obviously the brain, and any of you who've dealt with someone who's had a stroke or a TIA where speech is temporarily or permanently impaired, recognizes that the brain is the one who has the master control over the voice. And that innervation is involved with lots of different things that I'll show you, including that recurrent laryngeal nerve that innervates the vocal cords. But you also have, sorry, these slides did not transform very well, but the nose and pharynx are important parts of this. This is why your voice is different when you have a cold. The vocal cords have to function. The rib muscles are involved. The wetness of your lungs, believe it or not, has an important role in your voice. We'll talk about that in a minute because the way that voice recognition has entered medicine is really in the realm of heart failure, my particular niche in cardiology, and that's primarily due to wetness of the lungs, as well as the diaphragm. And many of you, if you've ever taken singing lessons, they focus on the diaphragm. And it turns out the diaphragm has also entered the realm of cardiology, both for diagnostic and for therapeutic purposes. So the first time in the medical literature that this was described was back in 1892. And it turns out the old clinicians, of course, could not harness any of the things I'm going to show you about because computers hadn't been invented. So they simply relied on listening to someone's voice. And they termed this the cardiovocal syndrome, because certain patients with certain heart diseases would have alterations in their voice, which were audible to anybody who would listen. The focus was on the nerve that I mentioned, and that's because the nerve that goes to the vocal cord wraps around many of the structures that are important within the chest. And this includes the aorta and the pulmonary artery and the receiving chamber of the heart, the left atrium. So when things happen in the heart, back in those days, for example, a common one would be syphilis. And syphilis, we don't see much anymore, but back then it would cause dilation of the aorta, and when the aorta stretched out, it would stretch the nerve to the vocal cords, and it would cause this typical hoarseness. The other thing back then that was common that we don't see much anymore was rheumatic heart disease, the consequences of streptococcal infection, which would harm the heart valves, leading to dilation of the receiving chamber of the heart, and that would also stretch the recurrent laryngeal nerve. So the first 50 years of this syndrome was really focused on rheumatic heart disease, syphilitic aortic aneurysms, large pulmonary arteries, and that kind of thing. And that's why there are articles in the literature. Here's one, Hoarseness in Heart Disease, from 1948. And it wasn't considered common at the time. In fact, they had only been able to find 30 cases in the literature. And of course, part of that is because most of us in clinical medicine don't write up every patient we see, so this is an undercount. But at least there were cases then, and you can see the etiologies listed there: mitral stenosis, which is the rheumatic heart disease, coronary disease, and they say here with congestive failure. That's what we're going to focus on in a minute. So let's look at how that might help me as a clinician, help you as a patient. Well, the lungs are critical, right? If you don't have lungs, you can't generate air to go through the vocal cords, so the lungs are going to be important in passing air through the vocal cords. The vocal cords will vibrate, and you can see depicted on the lower half of the slide the typical frequency spectrum that occurs when you sing or when you speak. Those vibrations then go up into the upper chambers of the airways, including the throat, the sinuses, the mouth, and all of those things end up on the right side with an output sound. And what that means is that if you can detect that sound, record it, and then dissect it, and you can digitize it, and with computers pick up these little tiny changes. We're talking about millisecond changes that are not audible to our ear, but which are dissectable using a computer. And doing so, then you can look at how are the lungs, how are the vocal cords, how's the throat, how's the tongue, how's the brain, etc. It's quite amazing what you can do. People who do this for a living break things down like this. So if there are any acoustic engineers here or people who do voice analysis, so this is, if you go to Silicon Valley and when people are doing voice analysis research, if you look at people who develop speakers, headphones, people in the digitization of music, etc., because the ear processes this information, these are the various parameters that they use to describe speech in a digital way. And these are the same ways that the software engineers have been able to harness to use the voice to detect and maybe therefore direct treatment of heart disease. You then compare people with heart disease to people who do not have heart disease, or you compare those people with themselves. And in fact, in heart failure, the biggest advance is comparing changes in the voice that occur in the spectrum of heart failure. You can then, this is a depiction, we're going to go into this a little later, but this is a recent publication where they compared in red individuals whose heart failure had decompensated, people who had heart failure who were temporarily worse, and then in blue, the same people, once you treated them and made their heart failure situation better. And you can see how distinctly different the blue line is from the red line. And this gives us an opportunity in an individual with a chronic disease like heart failure to delve into their health that moment, that day, and maybe determine that even before they're recognizing that they're having a problem. The beauty of heart failure is that when someone decompensates with a chronic disease, this isn't like having a heart attack where you decompensate in 1 minute. Turns out in heart failure, you decompensate over a period of 2 to 3 weeks before you recognize there's a problem. So this lead time allows us to distinguish the blue line from the red line and maybe make an intervention, whatever that is, to improve the person and prevent them from having a decompensation of heart failure. So you capture the voice by a smartphone or an app, and what has really made the difference here is the ability to digitally capture the voice using a smartphone. It is possible to do this on a landline, analog, but it's much better to use a digital voice. So when you have a person speak into their smartphone. Then you can capture that signal and dissect it. And then you send it into a repository of a supercomputer, basically. And as I'll show you the studies that have harnessed this, what they've done is they'll have a patient call in every morning or once a week and just repeat a phrase. And then they compare the digital voice of that phrase or phrases, and as I'll show you, sometimes other types of tests of the voice, and compare it with the person last week, 2 weeks ago, a month ago, etc. So let's delve into how that might work. The diaphragm, as I mentioned, is central to generating the air that is required for voice. And it turns out, listed on the upper half of the slide, the diaphragm acts in many ways during normal physiologic health. It is a pump. Every time you breathe, the diaphragm, a very large muscle, contracts, and when it contracts, it creates negative pressure in your chest, and hence you suck air from the outside world. And then when it relaxes, the elastic recoil of your chest exhales that air. So the diaphragm, of course, is critical. It's not mandatory. You can live without a diaphragm, but you won't be able to sing very well, and you won't be able to breathe very much if you don't have a diaphragm. And it also turns out, though, that in patients with heart failure, it turns out the diaphragm acts as a pump not just for air, but for blood. So every time you breathe, you suck blood into the thorax from the venous beds in your belly and your legs. And this assists the heart in its job. It actually primes the heart. And those of you in the know may know now that there are, and I think I have a picture here in a minute, they actually have pacemakers for the diaphragm to actually help assist the heart. And this may be a wave of the future of a way we can make a difference in a person who's suffering from a struggling heart by harnessing the strength of the diaphragm to actually assist in the heart's ability to pump. The bottom half talks about in a heart failure patient, things go awry. And it's actually been shown, if you've ever seen somebody who has chronic disease and how their muscles wither and they're weak, whether you have cachexia from cancer or from heart disease or a chronic infection or malnutrition, all those things you see in skeletal muscle, weakness and muscle atrophy, occurs in the diaphragm as well. And it's been shown in heart failure patients that their diaphragms are weak. And this, for example, worsens the heart failure state. So since I'm talking about heart failure, and that's our focus for the remaining part of the talk, let's define what is heart failure. So the important thing to recognize is that heart failure is a syndrome and not a disease. If you ask your caregiver, do I have diabetes? There are simple tests. Do you, yes or no, have diabetes? Are you pregnant? That's easy, just a test, yes or no. There is no such test for heart failure. It isn't like a single test or finding defines heart failure. So that makes it more challenging, and many of you who deal with patients, or perhaps yourself or your relatives, recognize that if somebody gets short of breath, for example, is that heart failure? Is it asthma? Is it emphysema? Is it because they have pneumonia? Do they have a blood clot? It's sometimes not easy to distinguish between those. And hence, there's an opportunity for better tests. And many in recent years have focused, for example, on blood tests to indicate that if there's the heart failure syndrome, certain blood tests become abnormal, and we can use those to help us. Oh, there is no single blood test that can define the heart failure state. So what happens in heart failure? The second line, the heart fails to deliver an adequate volume of blood at an adequate pressure. Your heart has to take blood from a pressure of 5 millimeters of mercury, or 10 maybe, and elevate it to 120 or 130 or 140 so as to allow blood to enter the rest of the body. And it has to do so in adequate volume so that the organs can work. It has to do so with the third line without flooding the lungs, right? If your heart works, but a consequence of that is your lungs fill up with fluid, then you have a very hard time breathing. And it turns out most heart failure patients have wetter lungs than typical. We can actually measure now in various means, either with x-rays or with various high-tech passing beams through the chest, measure the wetness of the lungs. And it turns out heart failure patients have wetter lungs. That's where some of the voice technology comes in, as I'll show you. And usually, on the bottom, usually but not always, there are objective findings such as the blood tests, or many of you have had echocardiograms to look at cardiac function. And hence we can come up with this global definition of this person has or doesn't have heart failure. Now, when you have heart failure, on the left in the orange, there are simple things in the diaphragm itself. This is a brand new concept in the last year or two, and if you actually measure diaphragmatic structure, diaphragmatic function, the physiology of the diaphragm, if you have heart failure, the upper green, you get shorter breath typically, or you have exercise intolerance. You used to take the stairs, now you take the elevator. You have to stop halfway up the flight of stairs. You're no longer doing housework. You don't go on that 2-mile walk, et cetera. You may have, in 50% of the time, your breathing is abnormal during sleep. And this is a complicated thing, but it typically involves the brain sleep center not working well for reasons that aren't abundantly clear. And then over on the right, in the yellow, it says muscle atrophy. This is a skeletal muscle. There are definitely differences in skeletal muscle, as well as I mentioned, the diaphragm. And all of these things are potential entrees into making a diagnosis or improving our care. Let me skip that. Oh, let me go back one. So I mentioned you can harness the diaphragm. Notice in the upper part of this picture, on the upper left, there's what looks like a pacemaker box. And most of you, if you know anybody with a pacemaker either is implanted now within the heart chamber itself or under the skin, and then wires lead from that pacemaker to the heart to stimulate the heart to beat. But if you notice here, the wires go to a nerve, and the nerve that they go to is the phrenic nerve, and that's the nerve that the body uses to innervate the diaphragm. And you can therefore pace the phrenic nerve to pace the diaphragm. That is now emerging, as any of you who have heard the term central sleep apnea, where the person stops breathing in the middle of the night, different than snoring. This is where the person just stops breathing, and you wait, and 20 seconds pass, and 30 seconds pass, and no breath has occurred. That's because the brain center that's supposed to stimulate the diaphragm is in kind of a sleep mode. So you can pace the diaphragm to get rid of that. That's a brand new way to treat central sleep apnea. But this particular pacemaker actually paces with the heart. And what it shows is that where it says treatment, and if you look at how people do, red is actually different than blue here. The control patients who didn't get paced versus the treatment patients actually felt much better and had better cardiac function if you pace their diaphragm with their heart. And I give credit to the electrophysiology colleagues of mine because they have begun to pace every part of the body from the gut to, I mean, who would have thunk it? But this is a new way to look at it. But if you look at a real-time voice analysis, you can detect early buildup of fluid in the lungs before the patient recognizes it. They may not notice that they're a little more breathless, et cetera. This is the promise, potentially, of this. If you know what the baseline is, and then you follow patients, I will guarantee you'll get about a 2-week lead time. And during that time, presumptively, you could do something. Usually when we say do something, what that means is change someone's medicines, right? Because we don't really have other means. You heard me talk, if you were here last year, about salt. Changing diet really does not affect this process at all. But what does affect it is appropriate adjustments of medicines. So let's see how this might work. So you have a patient, here it says acute decompensated heart failure on the upper left side, that cartoon in blue. The person unfortunately frequently gets hospitalized. We try to avoid hospitalizations. Hospitals are dangerous places, right? People get sick in hospitals and they're very costly. So we want to avoid somebody being hospitalized. We prefer to just treat them in the comforts of their home. But to do so, you would need to detect the decompensation before they got sick enough to present to the emergency department and end up in the hospital. So one way to do that is to record sentences as depicted here. In this particular study, and there are many different companies, much of this technology that I'm going to talk about came from Israel, and it actually came from military technology, as many of the things in Israel it came from, because they could detect in the voices of terrorists, for example, whether or not the intent was true, et cetera. So they'd voice record and then look for patterns. But they harnessed that to look for heart failure. Much of the other research has been done in Germany, and I'll show you that in a minute. But you record 5 sentences, and if the 5 sentences show that the digital signal of the voice is the same, you comfort the patient and leave them alone. But if it shows that there is fluid building up by this computer voice analysis, then you have this opportunity to make a change. And on the lower left, you can see that there are differences, and I'll show you the different signals here in a minute. But these are highly statistically significant differences in people that have heart failure versus don't. In fact, they're way more significant than looking at what most of the caregivers in this room look for. They're more significant, for example, than looking at changes in B-natriuretic peptide or N-terminal pro-B-natriuretic peptide or listening with the lungs or weighing the person, which is practically useless in this field, or looking at neck veins, or all the things that we have been trained to do. The voice recognition actually outperforms all of those statistically. So let's look at one clinical study. This one is from the Israeli data. And interestingly, this particular study enrolled 10,000 patients with, quote, chronic disease. Not all of them had heart failure. They also looked at patients with chronic lung disease. They looked at cancer patients, et cetera. But we're going to focus on the 2,200 patients that had heart failure in this analysis. Most of them had what we term in medicine as preserved ejection fraction heart failure. These are typically older women who've had high blood pressure, whose hearts don't relax normally, and the lungs may flood principally due to dysfunction of the relaxation phase of the heart. In this particular analysis, the average age was older. It was in the late 70s, typical of heart failure patients. And if you look at the third dot there, these people were incredibly well treated. And it's important to recognize that we have treatments that make a huge difference in heart failure. Many studies incorporate people that are on nothing. 98% of these people were on the so-called beta blocker class, like metoprolol being most common. 98% were on one of the renin-angiotensin, what is listed here as an angiotensin-converting enzyme inhibitor, like lisinopril, for example. 72% on a mineralocorticoid receptor antagonist, like spironolactone or aldactone. And 95% were on one of the cholesterol-lowering statin drugs. So these were amazingly well-treated people who were then followed prospectively just by having them speak into their smartphone. How did they do that? They had 20 seconds of speech in which the person would make a telephone call for 20 seconds. And in that 20 seconds, the computer detected different acoustic features. In this particular analysis, 223 different signal analyses from a 20-second voice sample. And listed here, and many of these mean nothing to the typical person, but you can analyze these every 10 milliseconds, and then you have an enormous set of data. And in fact, one of the reasons that this didn't come to fruition 25 years ago is we didn't have the simple computing power to do this. But it turns out we now do. And then they were followed over the next couple of years. Well, here's what turns out. If you simply record the voice and stratify people using this voice biomarker into how well will they do over the next 2 years, basically. And what you can see is that you can, just by a simple voice recording on day one, 20 seconds of voice recording will predict death dramatically. I mean, if you look at the people that had this voice biomarker that was in the furthest extreme from normal, listed here as quartile 4, their death rate was almost 3 times higher than the people who were in quartile 1. Despite being on the same medicines, despite being the same age, the voice predicted death over the next couple of years. Now, can you avoid that death with medicines? That's a more difficult thing. I will show you data that, in fact, you can impact this in a beneficial way. Here's what the spectra look like. And of course, these, to a non-computer, are very hard for us to dissect out. But some of them are very simple. This is from a complimentary German, which is why if you read what the patient had to read, if I had to read that, I would fail because I don't speak German. But this was just reading a 20-second German thing. And then they would ask the patients to count to 10, and then to count backwards from 10 down to 1. And then there's this really interesting test, if you've ever done this, called the Stroop word reading test. I think I have another slide on it. This is what you do, and you do that periodically. And what this integrates is not just, are the lungs wet? It also integrates things like, is your vocal cord working well? And also mentation. Because when people get sick, it turns out that translates. When you go home and your loved one is sick or your child is sick, their voice sounds different often. And we can even detect that with our brain, but the computer can pick this out and pick out little things. And here's what it showed in this particular study. In red and blue are the two different groups. Red is people with heart failure. Blue is somebody who is stable, who also has heart failure, but is not decompensated at the minute. And it's immediately obvious if you look at the difference, and these are all different ways, and each of these graphs compares voice analysis to some other metric that we have historically used in the heart failure community. So for example, upper left is the New York Heart Association class, which is very simple. You ask a patient, how are you feeling? Right? Turns out, how are you feeling is somewhat of a discriminator, but if compared to the voice analysis, how are you feeling flunks. It just doesn't do well. Do you have peripheral edema? The next one. Do you have ankle swelling? That's what that one is. How about listening with a stethoscope, Renee Lennox, 1816, not outmoded, but being superseded here by the computer. The red dots clearly discriminate better than listening to the lungs. And in the lower left, one of the newer babies on the block, the N-terminal proBNP, which is a blood test, which is very good. But again, the voice is better than the blood test at discriminating heart failure, right? Which is quite interesting. You then look at what happens when you change people. So if somebody comes into the hospital saying, I can't breathe, and they're in heart failure, not pneumonia or whatever, they can't breathe because their lungs are flooded, then you treat them for a couple days and you repeat the voice analysis on day 3. I mean, you're talking just a couple days. In red is admission, blue is when they're ready to go home. And what you can easily see is that despite various metrics, like on the upper right, is despite what their N-terminal proBNP peptide blood test showed on admission or day 2 or day 3, it turns out that the voice was a better discriminator of who was ready to leave the hospital. And this gives us insight. It often is Mrs. Smith ready to leave the hospital? Well, how do you know, right? We go in and ask her how she's doing. We listen to her lungs, which is pretty worthless in that, usually in that, to be honest. You might look at blood tests. Maybe you'll look at their daily weights, which, as I've already told you, is worthless. You can look at how much urine they've made, et cetera, and then you make a decision. Turns out that asking Mrs. Smith to talk into her voice, her smartphone for 20 seconds is a better way to determine whether somebody's ready to leave. There also are now emerging data that this works not just in heart failure, but can it work in coronary disease? The most common kind of heart disease that half of you out there have is to have narrowed arteries, right? Coronary artery disease. Now, it's much more intuitive to me that heart failure would be able to be dissected with the voice. Who would think that narrowings in the arteries would be predictable by voice? That wouldn't strike me as being even something I would look at, but it turns out, surprisingly, the answer is yes. Who knew? Voice prediction for coronary disease. Can voice predict how coronary patients will do? So many of you have had stress tests, and some of you have had angiograms and stents, and so one of the ways we've historically predicted how will somebody with coronary disease do is by putting them on a treadmill, asking them, are you having chest discomfort or angina, et cetera. Well, it turns out having them speak into the smartphone can predict how they will do. Again, who knew? So here is a prospective study. It's small, only at 108 patients, but they looked at speaking into the smartphone, analyzing in this way, and then asking the question, just this one time, analyzing their voice, how do those people do over the next 2 years? And if you had a bad voice biomarker score on the left versus a better one here, you had twice as much likelihood of having a heart attack or presenting to the emergency room just by a 20-second voice sample. How this works, we don't know. I mean, I can tell you that for heart failure, it's the lungs and it's the vocal cords and it's the diaphragm. How does it work to predict coronary events? I don't have a clue why that's the case. But they looked at all these different features, and that's what they found. So is it the lungs? Is it the voice box? Is it what the speech pathology people call the articulators, the tongue, the palate, the mouth, the nerve? We don't know, but there it is. So will this make a difference? Implicit in this is if you can predict the future, how do you change the future, right? That's the most important thing, because predicting that somebody's, if you can't make a difference, what difference does it make? I guess it makes a difference for financial planning and filling out your will. but it doesn't make a difference as a clinician to help you avoid the event. Well, one way it turns out has been in the literature is to nudge physicians and patients to do the right thing, right? And all of you who've been told by your loved ones or your clinicians, caregivers to lose weight, know that if you don't have a nudge, you're probably not going to lose weight, right? So one of the ways to have such a nudge is to have a refrigerator magnet with a picture of you when you were thin, and you put it up there. But it turns out that in prospective studies, the best way to achieve a goal is to actually nudge the clinician. So here was a study to say, if you nudged a clinician to do better care for high blood pressure, did it make a difference? And it turns out it does. And these data you can look up if you like. They're just very recent, this year actually. But it turns out if you nudge physicians to do greater care in terms of more intense lipid lowering, better blood pressure lowering, it does make a difference. So the hope is that in the cardiac world, if you can look into the future and say to your patient, you're twice as likely to have a heart attack in the next 2 years, we need to be more aggressive, that maybe in fact you will be more aggressive for things that we know make a difference, right? So it's not just heart disease. It turns out voice is being used in many other applications, many of them neurologic, where it would make kind of more sense. So this is one of the metrics being used in prospective Alzheimer's disease trials, and any of you who've dealt with dementia recognize that speech is an important deficit that is manifest in patients with dementia. And you can do many different types of tests using voice there, but even things in younger in life in kids with dyslexia and adult ADHD and ADD, Parkinson's disease. There was a very interesting article looking at detecting COVID long haul syndrome using these same voice systems that I've just said. So this is a field which is rife for exploration and I anticipate will be well utilized. So why does it make a difference in heart failure? Because we have impressive data that these medicines make an enormous difference. And I will tell you they're underutilized in America. If we had patients with bona fide heart failure who were appropriately using each of these medicines that I've listed here in classes, the renin-angiotensin modulators, beta blockers, the so-called mineralocorticoid receptor antagonists, and new on the block, the diabetes pills called SGLT2 inhibitors, which are now used in non-diabetics. Each of those adds 2 years of life to a heart failure patient. So if you knew somebody who had heart failure and you could project they're going to do more poorly, even using voice analysis, this is the way to do it. Use appropriate medical therapy, and then for some patients, lifestyle changes, exercise, and that kind of thing. So as I've said before, treating heart failure isn't rocket science. It's actually a lot harder than rocket science. And I used to work at NASA. Let me tell you, rocket science is just formulas. It's what you used to learn in physics, right? That's what rocket science is. But with personalized care, appropriate use of medicines, close follow-up, maybe using voice signals in the near future, many lives will be saved, and I thank you for your attention.
Okay, she needs no introduction, but I would love to introduce Dr. Nicole Weinberg. Through the Women's Heart Center at Pacific Heart Institute, she is the director of this incredible Women's Heart Symposium. She founded the Have a Heart, Save a Heart charity to increase awareness and prevention to the community and beyond. Please help me give a warm welcome to our Dr. Nicole Weinberg.
All right, everybody, thank you so much for coming. So my talk will be Heart Strong, Secrets to the Strongest Heart, and I am Nicole Weinberg. My slides will be up momentarily. I hope. And everybody's well fed? Very good. All right. So I have no disclosures. This is a CME and CEU talk, so if anybody wants to pay me for something, maybe I'll add something in years to come. But nonetheless, why should we care about heart disease? Well, heart disease is a leading cause of death. And not only is it the leading cause of death, but if you look at the next 4 causes of death combined, you add them all together, it still does not equal the amount of women that are dying from heart disease. So we have showed this slide before. We've spent about 10 years talking about this very subject, but really we feel our goal is to educate people on a much larger level. We go to the office, we tell patients all the time this same information, but we really felt like getting a room together with, 100 and however many of our closest friends was the best way to get this message across. So we feel that the heart is at the center. Not only is it at the center of your body, but it's also the center of attention. It affects disease processes throughout the body. So your brain health, your gut health, your digestive health, your endocrine system, all of these things have an interrelationship with your heart. But interestingly, if you look at Western medicine and the way we learn Western medicine, all the organ systems are very siloed, similar to my kids' puzzles that they have for the body systems. First, you layer on the circulatory system, then you put in the skeletal system, and everything is very subdivided. And that is very neat and organized as you're learning the different organ systems. But we understand that in reality, it's just mass chaos. Everything is interacting with each other. You've got hormones, you've got your heart, you've got your brain health, you've got your digestive health, and it's all coalescing at the same time when there's a disease going on. So we felt like this concept was extremely important, and it was something that we wanted to talk about on a larger level. So all of this started about 10 years ago in a land far, far away. We decided, let's have a Women's Heart Symposium. So in 2014, this was our agenda, and so we hosted 2 keynote speakers that year. Our first one was Cassandra Schufelt. She spoke about hormones and heart disease, and it was a fabulous talk linking hormones, heart, GYN issues. My talk that year was on cancer survivorship and heart disease, so a little bit of oncology, overlapping with cardiovascular health. And our second keynote speaker that year was one of our big champions of this meeting, Matt Budoff. Dr. Budoff came up from Harvard UCLA and gave us an amazing talk about screening for heart disease, radiation safety, and awareness as it relates to heart health. Our second year's meeting, we hosted Yuri El-Kayam. Dr. El-Kayam is a specialist in not only cardiology, but also OBGYN. And he did a talk on the management of heart disease in pregnancy, luckily about a month after I delivered my twins. Otherwise, this talk would have sent me into a little bit of a panic, probably labor. But nonetheless, it was a really engaging talk linking some of our obstetrical issues as well as cardiovascular health. In 2016, we hosted Dr. Arthur Agatston, who did a really wonderful talk linking nutrition, digestive diseases, and cardiovascular health. And Dr. Doshi, our famous Dr. Doshi, linked neurologic disease processes like stroke with atrial fibrillation and heart disease. In 2017, we had super famous Nanette Wenger. She is like the pioneer of all things women in heart. She started this conversation decades ago, and she came to us from Georgia to give us a talk about a timeline on how she started some of these interventions. Serena Vanderzee gave us a fabulous talk that year on exercise and your heart health, even as it relates to patients doing exercise, but also some of our athletes. She was a little ahead of her time in terms of some of the things that she discussed. And we also had Jennifer Beals give us speech, and we honored her for their innovation in designing the Heartland bra, along with our very own Sherry Ross, who I believe is still here somewhere. We have also helped them designing this bra to be worn with stress testing so that we can have our women achieve their goals in fitness when they're having their stress test. That way we can diagnose more cardiovascular disease and hopefully get to the people that need it most. In 2018, we had Dr. Roxana Mayren come, and to Dr. Itchhaporia's point, she really lobbied for us to be enrolling people, women in research studies, not only women, but women and men, to counter each other and understand why there are so many differences in our different disease processes and why we really may need to be looking at different therapies and ways to identify our patients. Dr. LaJoy also gave us a fabulous talk on complementary medicine, some emotional health, some Eastern techniques that can help our cardiovascular health. So that was in 2018. And Dr. Peter Pelican gave a fabulous rundown on angiography, coronary, peripheral, valvular heart disease. These are all the things that Dr. Pelican has helped pioneer within our medical community. In 2019, speaking of ahead of her time, we had Jane Burns. Dr. Burns came up from San Diego and gave a great talk about infectious disease affecting your heart. She was doing it in relation to Kawasaki's disease, but it really prepared us for some of our knowledge as it related to the pandemic the coming year. We also had Sarah Kate McGowan talk to us about sleep health and heart disease, which is a really emerging field, as well as Maggie Izid and Carrie Ikamoto, who both spoke about environmental toxins and nutritional toxins and how they affect your heart health. In 2020, right before the pandemic, we had the famous Martha Galati come and speak to us. She spoke on women and heart disease, and is there really a sex difference? And she really helped elucidate some of the things that we had talked about before, linking different disease systems and our heart health. And then we had maybe my favorite speaker of all time, my father, who spoke to us about, on a panel about different universal healthcare and some healthcare reform and how we can really advocate for our healthiest self. In 2021, when we were on lockdown, or I guess the ballroom was at least on lockdown and we couldn't come in and do presentations, we had Joanne Manson patched in from Boston. She gave us an amazing talk about supplement health, vitamin D, fish oil, how this affects your heart health, how this affects your bone health, how this affects your cancer risks. So she really covered a lot of different territories for us that year. Last year we had Dr. Athena Pappas. She came and did a sex-specific risk factors for women talk. So again, really melding some of these different organ systems and women's cardiovascular health. We also had Rigvid Tadwalker give an amazing speech about artificial intelligence and some of the new technologies that had come down the pipeline during the land of COVID, where we were checking ourselves at home and trying to understand, is this data important? Is this good? When do I call my doctor? So that was Dr. Tadwalker. And Dr. Richard Wright, if you have paid attention at all to my agenda slides, you'll see his name is in, I think, every year. He has given an updates talk, and so we are so appreciative of that. I highlighted the 2022 because I think that was the one we got the most feedback on, because that was the one where he told us salt is actually good for us. And so it still rings true today. We still hear a lot about that. We touched on COVID, so we revisited some of the infectious disease and cardiovascular complications issues. And then this year you've heard from Dr. Dipti Itchhaporia with the most amazing talk about leadership in cardiology. And I think it speaks to the fact that we're not necessarily just trying to train female practitioners, but really because women see women a lot of the time in terms of their practitioners, we really feel like we need to advocate for each other. So it's not just about training female medical professionals, but it's really about elevating all of our healthcare. So we feel like we've had the best and the brightest speakers for our Women's Heart Symposium over the past 10 years. This is a highlight of our amazing speakers. But also this is a special highlight of our Pacific Heart Institute speakers. They are our amazing local celebrities and national celebrities. But at any rate, the heart is the center of attention, but it truly cannot do it alone. We've hopefully shown that with all these different agendas and all the different topics, that it really requires a multidisciplinary approach. It's not just looking at the heart alone. It's looking at how the heart interacts with all the different organ systems. And we really understand that we need to look at the full person. It's not just about looking at the siloed cardiovascular system. We feel this is the premise of our Women's Heart Symposiums. This is why this all started. And we have a few secrets to impart upon you today. So I'll start with 3 of our top secret information. So Cardiorheumatology. So this is a emerging subspecialty field within cardiology. Why is it important? Well, if you look at autoimmune disease, it affects women 3 times more than it affects our male counterparts. So I see a lot of patients with autoimmunity in my practice, and they do have pretty aggressive disease that we need to pay attention to. If you look at patients with lupus, for example, they have a 50-time higher rate of having cardiovascular disease than their age-matched cohort that do not have lupus. So a 50 times higher rate of disease. Additionally, if you look at patients with rheumatoid arthritis, their life expectancy is shortened by 10 to 15 years because of that diagnosis. So that may sound very strange to us. Well, so they have joint problems. How does that affect their heart? Well, this is part of the things that we're going to be talking about today. Once upon a time, in a land far, far away, in 2003, I fancied myself a budding rheumatologist, and I thought I was going to be the national expert on scleroderma. And this was a paper that I worked on when I was in training because I just thought the disease processes were so interesting. Rheumatologists are such puzzle solvers because the disease processes affect so many different organ systems in their body. But I ended up sticking with rheumatic heart disease instead of rheumatoid arthritis. And so to stick with that, we have all the different aspects of the cardiovascular system that the rheumatologic disease processes affect. If you look at our vascular system, we have increased deposits of plaque within the system. We have vasculitis, so inflammation within the linings of the vasculature. We form clots. We have Libman sacs, endocarditis. We have inflammation within the lining of the heart sac, pericarditis, as well as pericardial effusion, so fluid that can build up in there. We also have thickening of the heart muscle and fibrosis within the actual tissue of the heart. And then we also have conduction disease processes, so either heart blocks, so very slow heartbeats, or really fast heartbeats. It's important to kind of tease out with these patients, well, why are they having it? They've got not only traditional, but also non-traditional risk factors. And so this is going to be kind of a theme that runs through a bunch of our different secrets today, that we have to understand that our rheumatologic patients have amplified traditional risk factors. Maybe they're not exercising as much because their joints hurt them. Maybe that they're not exercising as much leads to for them to have some extra weight, and they may fall into a category of obesity. They may have medication compliance issues, not because they don't want to take their medications, but because they have side effects to some of these medications. Additionally, there are some patients with different types of vasculitis conditions, such as Berger's disease, that may end up smoking a little bit more because some of that relieves some of their other symptomatology that is affecting them on a more regular basis. And then we'll also get into the lipid paradox in a second. These patients also have non-traditional risk factors, and a lot of this has to do with the fact that they have a chronic inflammatory response going in their system all the time. So it sets off a cascade of these aggravating factors. So all these proteins get released into their system, and they start building up more plaquing, and they have more risk of thickening and hardening their muscle, and they also have more likelihood of having clots form in their arteries. So if we dial into the lipid paradox for a second, this is a slide that we've also talked about because we've digested that looking at the traditional LDL, HDL, and triglycerides is a good test to do, but there are some advanced lipid tests that one can get when they go to the doctor's office. And so if you strip the membrane of the LDL and you count all the particles that make it up, you may actually see that a patient has very high particles in their system, and that high particle number may actually mean that they have a greater likelihood of depositing plaquing in their arteries. So what does that mean for our patients with rheumatologic disease? I see patients that come in all the time and they say, I have no idea why I'm here. My LDL has always been very, very low. How do I have plaque throughout my arteries? How did I need a stent? How do I have coronary artery disease? Well, we realize that these patients actually have a very high particle number. So they have a discordance between their LDL being low, but their particle number being very, very high. And so you can see on this graph that the patients that have a very high particle number are actually having many more cardiovascular events than their other counterparts that may have a higher just LDL without a high particle number. We believe a lot of this is related to this chronic inflammatory process that they have in their system. So it begs the question, how do we treat these patients? So we now are identifying that these patients have high risk. Do we treat their cholesterol? Do we treat inflammation? How do we make sure that they live a healthier life? Well, so if you look at some of our traditional therapies, for example, for coronary artery disease, we oftentimes look at statin drug therapy as our mainstay of treatment. But this can be very difficult for a lot of our rheumatologic patients because one of the biggest side effects associated with statin drug therapy can be joint aches or myalgias, muscle aches. And so it's for this reason that they may not be able to be compliant with their medications or just not really be interested in taking them at all. Additionally, some of these patients may be more predisposed to a condition called rhabdomyolysis, where they have elevated levels of muscle breakdown products in their system. So when you give them this drug, they may react quite poorly to it. But all is not lost. There are some newer drugs that seem to be working well in our rheumatologic patient population. We have some water-soluble statins, things like rosuvastatin or pitavastatin. These are drugs that the byproducts of the drug don't seem to stick around as long as some of the more fat-soluble statins. We also have some injectable cholesterol medications, which are the latest and the greatest on the market these days. These drugs, the PCSK9 agents, as well as inclisiran, work on clearing the LDL out of the system. And so they use a completely different mechanism of action than the statin drug therapies. And because it's a different mechanism of action, we have found that a lot of our patients with rheumatologic disease tolerate these classes of drugs a bit better than some of the other drugs that we have used in the past. Additionally, we have non-traditional therapies that are becoming really helpful to treat our patients with rheumatologic disease processes. They fall under a category of immunomodulating agents. So they're a little bit more high-tech in terms of some of the pharmacology related to the treatments. In the past, for inflammation, we used to put everybody on steroids, or we used to give patients NSAIDs. And these drugs have other ramifications as it relates to your overall body health. We now have newer agents such as rilonacept, which is a drug that is used to treat recurrent pericarditis. So again, once upon a time where you have inflammation or fluid building up within the sac around the heart, we used to give steroid or we used to give NSAIDs. Now we can give this rilonacept, and it blocks the inflammatory cascade for the interleukin-1 pathway. So it is really revolutionizing our care. It doesn't all have to be fancy new drugs. There are really interesting studies looking at patients with chronic coronary disease and giving them medication like colchicine. So that's a medication that maybe a lot of you may have heard of because it's used for gout, which is an inflammatory condition. So this study looks at patients that have been very well treated for their coronary artery disease. They may be on the full cocktail of medication, but despite it, they're still requiring more stents, bypass surgery, and they're having progression of disease. They looked at putting these patients on colchicine, 0.5 milligrams once a day, and they showed that they were able to significantly lower their progression of disease by using this type of medication in conjunction with traditional cardiovascular therapies. So we feel like targeting the inflammation is really important, and that's one of the points when we're looking at summarizing our findings with our cardiorheumatology. We find that there is a very strong overlap between rheumatologic conditions and cardiovascular disease. We know that there's a significant increase in cardiac morbidity and mortality associated with lupus, rheumatoid arthritis, and numerous other autoimmune diseases. And we feel that in terms of our therapies, we must target not only traditional therapies, but also these non-traditional endpoints so that we can adequately treat cardiovascular disease in our rheumatologic patients. So that was my first secret. So moving on to our second secret. So we're going to talk about cardiogastroenterology, and I know you probably all think, well, I know what this is all about. It's all about GI bleeding. And this is really the bulk of the literature in terms of cardiogastroenterology. If you look this up, a lot of it has to do with the fact that we as cardiologists love blood that is thin. Everybody comes in and tells us that they're bleeding and bruising everywhere, and but But if you are a patient who has coronary disease, or if you've had stents placed, we like our patients to be on antiplatelet therapy. And if they have a fresh stent, we like them to be on dual antiplatelet therapy. So we may put them on 2 drugs that target the platelets. Then you have your patients that have atrial fibrillation, and we want to thin their blood with medications like warfarin or some of our novel anticoagulants. And so then you can imagine the patient that has coronary artery disease and atrial fibrillation. We put them on triple drug therapy, and they're bruising and bleeding everywhere. And so maybe it's not a huge surprise that they may have some bleeding issues. But when Dr. Arthur Agustin came and spoke to us in 2016, he was really helping for us to pioneer the thinking that your gut health is so linked with your cardiovascular health, because he had done a lot of preliminary research looking at inflammatory bowel disease. So patients that have ulcerative colitis, patients that had Crohn's disease, and saying, you know, the leading cause of death in these patients is cardiovascular disease. So it's really important that we work with our gastrointestinal colleagues to really identify these patients with and understand where their risks lie so that we can treat them, because we feel like this chronic inflammatory state is really causing a lot of the issue. Interestingly, if you look at a lot of his data, it's not just to say that these patients have bad cardiovascular disease, but it's also to say that women suffer more. So women with inflammatory bowel disease had higher rates of having heart attacks. Women with inflammatory bowel disease have higher rates of GI bleeding. So also working with our gastrointestinal colleagues to really identify these patients so that we really know what's going on and who is at risk is critically important. But why is all of this happening? So again, hearkening back to some of these inflammatory markers, we know that when these patients are in their state of inflammation, that they're releasing a lot of these markers into the system. So they're having CRP, interleukin-6, TNF-alpha, and they're all circulating in the system, activating the blood vessels to build up more plaquing. They also can cause some dysfunction in the innermost lining of the blood vessels, so that's the endothelial dysfunction piece. And additionally, these patients can be at higher risk of forming clots in their system. So when you put it all together, they really have a lot of risks of having cardiovascular events. So the reason for identifying some of these issues is not just to say, well, the patients with inflammatory bowel disease are an isolated group of high-risk patients. It's to basically start to identify that maybe they have some problems with their microbiome, and maybe this is something that we need to start paying more attention to. What is the microbiome? Well, it's a collection of bacteria and viruses and fungi that live in and around our body, but it is the thing that is our host defense mechanism. This is what helps us fight infection. It helps us prevent inflammation, but if you have some disruption, you're going to have chronic inflammation, and this is something that we have been seeing a lot within the literature looking at oral, gut, and vaginal microbiome health. So it's this dysbiosis, which is the change in the composition, the diversity, and the metabolites of the microbiome that makes somebody go from being perfectly healthy to being very sick in a short period of time. So this is something that they have identified within the inflammatory bowel disease community, the Crohn's and the ulcerative colitis patients. But also if you look at patients that have had some antibiotic use, we all have seen patients and know people that have ended up with C. difficile after being on antibiotics. That can be a disruption within the microbiome. Additionally, small intestinal bacterial overgrowth, or SIBO, is something that we've been seeing a lot of. And again, there's a disruption within the microbiome. And if you look through some of the more recent literature, they're looking at the microbiome and saying that it plays a huge role in the development of obesity, type 2 diabetes, food allergies, asthma, and dermatitis, all inflammatory diseases. But why am I bringing this up? I'm a cardiologist, and this is not my area of expertise, but if you look at patients that have periodontal disease, so we've known for years and years and years that people with chronic poor oral health or tooth loss, they have increased risks of heart and cerebrovascular disease. Well, why is that? they are having a constant seeding into their blood of all this bacteria. And the bacteria could cause a buildup of plaquing in the system. It can cause us to have endocarditis. It can cause us to have clot disorders. And it's not something that can be treated very easily. It requires 6 months of pretty consistent and quite aggressive therapies to start to improve just the little innermost fixes within the endothelial lining. And so it's a really big issue within the oral health discipline as it relates to cardiovascular disease. Additionally, if you look at the vaginal microbiome, there's a lot of data that says that fertility is very much tied to the vaginal microbiome. And so for people that have had infections in the past, they may have pH changes, they may have some scar tissue. This harkens back to some of the data looking at pelvic inflammatory disease processes, and that there is so much scarring that the patients have such a difficulty getting pregnant and or staying pregnant. And I found this interesting article that looked at a maternal microbiome when a mom is pregnant, if she has disruptions in her oral, her gut, or her vaginal microbiome, that it ultimately affects the placenta microbiome. And so her offspring may be born with inflammatory diseases, metabolic syndrome, as well as hypertension. So it really kind of challenges our thinking in terms of, is this a genetic predisposition? Or is this an environmental state? How do we make sure that we have the healthiest people coming into the world? So dialing back to cardiovascular health, if you look at gut dysbiosis and cardiovascular disease, this is a really muddied slide, but it shows that there are so many different high and low degrees of microbiota that we see in your gut and the different cardiovascular disease processes that go along with this. So for example, if you look at people with stable chest pain, stable angina, or people that have a history of heart attack, or they've had stents or coronary artery disease, they may have high amounts of lactobacillus. And so these are different types of microbiota that we would potentially want to be identifying and treating, because maybe we would be able to make these people healthier moving forward. But the dysbiosis treatment is not so easy. There is a lot of interest within this area. There is a lot of research. There are proposals of treating with broad-spectrum antibiotics. There are proposals of looking at pre- and probiotics. There's fecal transplant data. But really, the jury is out. It doesn't seem like any one of these things is going to get you from point A to point B. And it probably is even more different things than this to get your microbiome back on track and reduce that degree of inflammation. So in summary, for cardio-gastroenterology, gastrointestinal bleeding is a consequence of standard cardiovascular therapies, including antiplatelet and anticoagulants. The leading cause of death within patients with inflammatory bowel disease like Crohn's disease and ulcerative colitis is heart disease. And our gut, oral, and vaginal dysbiosis can lead to heart disease, but the treatment is likely multi-tiered. So for our last secret, once upon a time, in a land not so far, far away, there was considered to be no linkage between our emotional state and heart disease. So there's this paper from 2001 that stated there's been 20 years of data showing no cause and effect linking emotional state and cardiovascular disease. And I'm happy to say that we don't believe that anymore. We now actually have syndromes that have the word stress in it, like stress-induced cardiomyopathy or Takotsubo syndrome, where we know that there is a big stress surge that leads to cardiovascular disease. So what is Takotsubo syndrome? For those of you that have never heard of it before, you have a big emotional stressor, held at gunpoint, death of a loved one, something very, very profound. And this stress surge triggers a release within your hypothalamic pituitary adrenal axis. You have all these catecholamines that surge into the system, and it causes your heart to balloon out. And the shape of your heart as it balloons out is called Takotsubo, or octopus pot. But it doesn't have to be that dramatic. It can be something just kind of more mild. If you think about traditional risk factors and you think about patients that come to the office, one of the main things that they say is, oh, my blood pressure is up, I have white coat hypertension. You know, they come into the doctor's office, they're stressed, and their blood pressure goes up. Well, what if that happens all the time? That may be a risk for cardiovascular disease. Additionally, we know that patients that may be under stress may have some dietary indiscretion, and sometimes their cholesterol may be not quite optimal. They can have weight gain associated with this and ultimately blood sugar issues. And additionally, some stress management that people turn to are cigarette abuse or substance abuse to manage their stress disorders, and that can have effect on their cardiovascular risk factors. So where does traditional meet non-traditional? Well, there is an 80% increase in cardiovascular disease in patients with depression. So 80%. So we know that it is critically important to identify our patients that have depression and understand what is causing this so that we can hopefully treat them and they won't have cardiovascular disease. We are understanding that their cortisol levels really activate a level of inflammation, and it's that same feedback loop that we've talked about before. You have these activated levels, you have high cortisol, you may have decreased exercise, you can have weight gain. The smoking interplay is very significant, and it kind of goes round and round and round, spurring on a lot of aggravation within your cardiovascular system. Additionally, we are what we eat, and so in a land where we're maybe stressed and eating poorly, we may have some high levels of saturated fats in our diet and some low levels of polyunsaturated fats. And if you follow up the side of the cascade, you can see these foods can trigger obesity, and then obesity will ultimately trigger some insulin resistance, which will ultimately trigger a dopaminergic dysfunction, and that leads to brain health issues. But if you go the other way, the increased circulating levels of the saturated fatty acids in their system can lead to brain inflammation by having activated microglia. And these are cells within our brain that release different cytokines and different hormones into our system, and that can directly link with mood disorders as well. It's actually a hot topic within the pharmacologic therapy range because they are now trying to work on drugs to block these activated microglia and hopefully help mood disorders. So how do we treat these patients with emotional issues that leads to cardiovascular disease? Well, the treatment is probably a lot of what your mom told you at home. You've got to eat healthy, you've got to exercise, you've got to go to your medical practitioner and have your regular health checkups. But maybe also folding some meditation in can be really helpful, as it doesn't necessarily put more drugs in an already aggravated system. It gives you the tools to do this on your own. So biofeedback within the world of medical research is actually pretty well established. This is something that we've been looking at for quite some time. The biofeedback breathing that we've talked about is that slow rhythmic breathing in through the nose and out through the mouth. It can be really helpful for patients with blood pressure issues, arrhythmias, fast heartbeats. It can also be really helpful for patients that have myocardial ischemia or decreased blood flow through their heart arteries. If you look at your heart arteries, the way the blood flows is kind of similar to what your pipes are doing in your house. So you really do want to have that laminar flow, that straight flow of blood through your arteries. And when you have certain stressors in your system, when you have high cortisol surges, you end up with turbulence of blood. And that turbulent blood flow can be very activating within the system. It can cause irritation, it can cause endothelial dysfunction, it can cause more plaque buildup, and sometimes it can even a plaque break off, and you can end up forming clots within your blood vessels. So really learning to get your blood flow nice and laminar through some of these breathing techniques can be really helpful, and it's something that people do use in the office for their patients that are compromised. We know that some of the biofeedback literature has been really prominent in the world of hypertension. So if you look at the patients that have high blood pressure and you put them on a regimen of biofeedback, deep breathing, you can lower their blood pressure by about 15%, which is better than many pharmacologic therapies on their own. So we understand that this is really great, reproducible data, and it's something that people can do by themselves without being on drug therapy on their own. So our cardio-emotional health journey, in summary, lends us to understand that there is significant evidence linking our emotional well-being and our cardiovascular health. We understand that eating poorly affects not only your traditional risk factors for cardiovascular disease, but it also increases brain inflammation. And biofeedback is a well-established way to treat hypertension, arrhythmia, myocardial ischemia, and probably a lot more. So those are my 3 secrets, and really we have a lot more. I am just scratching the surface with these talks. I could probably have talked for hours and hours and hours on each of those points individually, but this is kind of where you come in. We understand that the body is complicated, and there are certain things that we as practitioners think are really important, but there are other things that you all think are really important, and we'd like to continue the conversation. Heart disease is the leading cause of death, and unfortunately, because the numbers are so high, it's probably not going anywhere for a while. So we really need to get this community education piece out there. We need to get the message out, not just locally in Los Angeles, but also around the country and around the world. So we are introducing a program today called our Hearthside Chats. And so this is our quest for more community education. We want to increase this conversation. We want to talk about all the linkages between your heart health and your other organ systems. We want to do this with you in the community, not just once a year, but more frequently. So we'd like to involve you all with this. We want to gather some small, intimate groups. We want to gather some experts to meet with you and have these talks, these Hearthside chats, so that we can figure out how we can reduce the leading cause of death and really isolate what are the things that are important for your knowledge so that you can reduce the risk of cardiovascular disease within your family and your community. We feel if we do this all together that we can be heart strong. So coming soon, Hearthside Chats. Feel free to scan the code. You can plug in your information, tell us who you are, what topics you want to talk about. If you want to host a chat at your home or a local venue, we would love to do this with you so that we can increase this conversation and hopefully reduce the risk of death. Thank you all for paying attention.
Right. So as we're waiting for the questions to trickle in, I thought we could start with Dr. Itchhaporia, who talked about such an important topic, which I think is really close to me, having critical mentors that guided me through my career into cardiology. I wanted to ask how you've seen it translates into the community and taking care of patients, having female cardiologists in many different areas of cardiology in our community and what that means.
So I think the first thing is the idea that just on the heels of Nicole's talk about women and heart disease, I think that when a woman now has chest pain and has an angiogram that's normal, we don't just say, oh, you're fine. We sort of have been digging deeper to see, are there any other causes? And I think that having women at the table has sort of push that conversation that women and heart disease is an important issue. Not that the men didn't think it was an important issue, Richard.
No, we thought it wasn't.
But I will say that I think that we are, this idea of being dismissed. I had a woman early on in my career that would pass out all the time, and we did a tilt table, and it was positive. And she burst out into tears when I told her what her diagnosis was, because she said for years she had been passing out, and she's a dancer. She likes to dance with her husband. And she said she literally was told she was hysterical and was dismissed. And so the idea that I think, I think have brought a greater awareness of the issue. And then, like I said earlier, I think that there are women that want to go and see another woman. They may be embarrassed to share some of their issues with a male cardiologist. So I think all of that has helped.
Great. Thank you so much. Dr. LaJoy, I think we have a question in the audience.
Hi there. Thanks so much for great talk and sponsoring women and mentoring women in medicine, and happy Women's Physicians Day. I do have a question for Dr. Wright. As a gastroenterologist, I see people with hoarseness all day long, and we all know that's acid reflux. But I'm just wondering, how should I be sending a lot of my hoarseness patients to cardiologists, because it's nothing I have thought about before?
Yeah, I mean, I think no would be the short answer to that. So hoarseness clearly can occur, and if you want to look at recurrent laryngeal nerve issues, in the oncology world, if somebody newly has hoarseness, they're always thinking cancer and that kind of thing, which can occur. In cardiology, for just hoarseness per se, an echo basically will tell you everything you need as to whether or not the recurrent laryngeal nerve might be the cause, right? So if somebody has a normal echo, they're not going to have recurrent laryngeal nerve dysfunction due to heart disease. However, as we learn more about this, and for your hoarse patients who indeed, maybe it is acid reflux, the important things that I talked about for voice analysis are that his or her baseline is going to be hoarse. Then little minute changes that occur on top of that would be detectable by voice analysis. So in the emerging era where smartphones will be an enabler for us to pick up people with early disease, it doesn't matter whether their baseline is hoarse, because that's going to be eliminated. They're not going to be compared to people who sing opera for a living. They're going to be compared to themselves.
Right.
So I think chronic hoarseness may indicate heart disease, unlikely these days. It's these little minor things that we can't appreciate with our ears that the computer can pick up.
It's really fascinating. Thank you.
Well, we're grabbing a question from the other side. I'm just going to add to that. I have a patient with heart failure who's an actor who doesn't take his diuretics because it makes his voice too high-pitched. And so what I'm learning from you is maybe his high-pitched voice is his normal voice.
No, give him testosterone, would you know?
Dr. Itchhaporia, I'd like the penthouse, please. My question to you is, and I have one for Dr. Wright as well, is there data documenting the percentage of women seeking female cardiologists, and is there data documenting the percentage of men seeking female cardiologists? Dr. Wright, simple question, where is this test being performed in Los Angeles?
So no, there's no actual data, but I will tell you that when you do patient surveys, the patient surveys will say how many women actually say they want to go see a woman cardiologist and how many men, and the reflection of how that interaction is. And actually, I was told at the break that Dr. Wright, that Dr. Frankel, who was in the audience, said to me, maybe you should include that in your talk, because there is data that both men and women seek out women, but I don't have the actual numbers.
Those numbers are available, like in obstetrics and gynecology, for example, where there may be more sensitivities to the gender of the doc treating it. But I would actually like those data, because I don't know what those numbers are. I don't know that any place right now in Los Angeles has this. There are, as I mentioned to some of the people at the break, there are at least 3 different companies that are in this spot. One of them does have a commercial product that they're entering into the market this year, and the others are close on their heels. So I think it will enter prime time sometime in the next year, right? And part of this is when you heard Dr. Tadwalker's talk in years past about wearables. One of the things we as the treating people are afraid of is being overwhelmed by data, right? So you can imagine if my 2,000 patients all send me voice signals every day, it's like, you kidding me? You know? So we have to have the computer systems to be able to filter the data and only give us a true signal. And as was pointed out by the previous question about hoarseness, if you had a cold today and your voice changes, the good news about heart failure in particular is that there's this 2-week lead-in, as I mentioned. So maybe if your voice changed for 2 days and then it regressed back to normal, we don't have to do anything because you just had a virus or who knows what. And this will all play out as we get more data. We're really in the infancy of this particular tool.
Hi, I recently heard that the fish oil was not helpful anymore, and I'd like you guys to comment on that, and if it helps the brain, the heart. Thank you.
Yeah, so years ago, so the question was, what's the role in 2023 of what is termed fish oil? Okay, so a couple of comments about that. So first, fish oil isn't made by fish, right? Fish is plankton oil. It's made by plants. So it's really plant oil. And those oils are not made by us. So they're essential because humans don't have the enzymes to make those particular fatty acids that we lump together as called fish oil. We all have that because there are plants that don't come from the ocean that make similar things. So if I were to go around the room and measure everybody's fish oil level, and you can do that, if you look at your cells, you can actually ask what percentage of the fats within, for example, red blood cell membranes come from what we would collectively call fish oil. In this audience, the answer is probably 4%. LA has a little bit of a higher level of fish oil than do most Americans. If you go to Nebraska, for example, it's about 2% because they eat more corn and meat and less, things from the sea. If you go to Japan, the average person is 8%. And then if you do a correlation just looking at fish oil levels versus eventual risk of heart disease, there is a correlation. So people who have more fish oil in their system seem to do better. And that led people to say, well, let's give fish oil to everybody, hoping we can prevent cardiovascular events. That study, even in Japan, did have merit. But when you repeated those studies, larger populations, for example, just adult Americans, let's give half fish oil and half not and see how they do, you couldn't prove that there was a benefit. So there is a little bit of truth to what you said, which is that fish oil for everybody, but you can make the same argument, as you've heard from previous speakers in years past, that vitamin D, for example, that doesn't help the general population, neither does any vitamin that we've ever been shown. So you have to select in whom might it be helpful. And the data are clearest on those people who happen to have high triglyceride levels, because if you give what we would term pharmacologic doses of omega-3 fatty acids or fish oil, those people can have their triglycerides be lowered, and that might be useful for them to prevent pancreatitis and other things. So there is still a role for fish oil, but a general blanket statement that everybody in this room should take a capsule of fish oil probably is misplaced and is no longer true. And I'd openly invite anybody else.
I think you covered it.
I agree.
Hi, I have a question and maybe a topic for a Heartside chat. I'm a pharmacist by training. I was wondering if the panel has any recommendations on clinicians on the front line, doctors, pharmacists, nurse practitioners, nurses, on how they can manage patients who are getting their information from the lay press, Facebook, YouTube, Dr. Oz, that this is not the way to manage your medication. You shouldn't stop taking your statin because somebody says it's poison. You shouldn't start on a high-dose niacin because it's benign. There's a whole big issue with patients just undertaking it to just manage things on what they hear. So I was wondering if you had any opinions on that and maybe some solutions. Thank you.
I can guarantee you we all have opinions about that. Whether we have solutions, I'm going to turn to our august past president of the American,
I think this is a real problem because obviously during the COVID era, there was a lot of miscommunication that occurred. And as a result, unfortunately, there were people that, didn't adhere to therapies or didn't embrace certain therapies they should have. I think that this has become an issue that's come to the forefront, and I do think professional organizations are starting to say we need to address this issue of miscommunication. I also think that clinicians have a role in making sure that we're transparent and direct with our communication and how we actually talk to the patients. I think patients need to be heard. Remember what they say, you have to be able to listen to what the patient says. So instead of just and there are times when patients will say something that's so off the reservation that you say, oh, that just sounds crazy. But that's not what you want to do. You want to say, I hear what you say, but there's a whole body of literature that is in the science, and it's steeped in science, and this is what that has shown. So I'm not sure that we as a community embrace some of these other recommendations because I don't know what the data behind that is, but we do know the data behind this. And so have that conversation with the patients. But I do think there's going to be more and more stuff coming out about miscommunication, and that's going to probably require even legislative oversight to sort of remove some of those things that are misinformation off the social media platforms.
And I would agree with you that it is a great topic for our Heartside chat, because I think that was also the premise of us doing this meeting today. Instead of everybody saying, well, I hear this is really good for you, we could say, great, you've heard that. Let's give you some data to either support or refute that as something that you think is really good. And so I think that this is a great mechanism for that. And so and if somebody's taking notes, I'll have a mental note on that.
And it's not just social media, as you said. That's been the biggest offender because there's no filter at all. So, you could put out some premise that that's so bizarre, it may even be harmful, that people might buy into. But even the mainstream press, where there are editors and curators. So, for example, a good example was the study last year about aspirin use, right? So, and those of you who heard my aspirin talk in the past, right? This came out of a general practitioner in Glendale who first made the observation that people had fewer heart attacks when given aspirin, and that has been one of our mainstays of therapy. So then the question was, should we, as with the fish oil comment a moment ago, give aspirin to everybody? Let's give a baby aspirin to every adult in America. The problem with that is that half of the American population won't die of heart disease, doesn't have really significant coronary disease, and hence wouldn't be expected to benefit from a baby aspirin a day. And indeed, that study showed that if you give aspirin to healthy people who are over the age of 50, who have no history of heart disease, you save a few in terms of heart attacks, you cause a few bleeds, and in the end, it was a wash. And then the press took that and said aspirin's no longer useful for adults. Which was the wrong interpretation, because they left out this sentence, adults who don't have heart disease. And so the Peter Pelicans of the world who put in stents and are aghast when somebody stops their aspirin, those people were harmed by a misinterpretation of a legitimate study. And so it's important to have somebody who knows what they're talking about present information to patients individually and to the public.
Do we have any questions from our virtual audience?
Yes, absolutely we do. A couple of questions, but I'll start with the first here. So for the panel, how does the effectiveness of AI technology compare to cardiomems in heart failure?
So cardiomems, for those, there are ways we can measure pressures inside the heart, right? So the traditional way has been for the interventionalists of the world, like the woman to my left, to thread a little tube up into the heart and actually measure pressures. You're used to having your pressure measured in your arm for a blood pressure, but we can thread a tube into a blood vessel and directly measure the pressure there. And hence we can measure pressures inside the heart and inside blood vessels, et cetera. People have miniaturized this, and so you can put a little pressure sensor inside the body. In theory, you could put it anywhere. The particular device just mentioned is put into the blood vessel that leads to the lungs, and you can constantly, beat by beat, measure pressure of the blood flowing to the lungs, and that will give you insight into the heart's function. The problem with that approach is it's expensive, it's invasive, meaning you have to put a tube into somebody, and it's not broadly applicable. If you want to treat 180 million Americans with heart disease, you don't put implanted monitors in all of them. So the beauty of something like AI is it can harness what everybody in this audience has, which is a telephone somewhere, probably right now in their purse or on their body, and use that information. So I don't think they replace each other. To Dr. Tadwalker's question from the virtual audience, I think they're complementary, but I think that the future is brighter, in my view, for using AI.
Can I just add one more thing? With AI, I think that medicine is becoming a data science, and so we're deluged with data that people get from their smartphones for the EKGs and all kinds of things. And there is no way that a clinician can take all that data and make sense out of it, and this is where AI comes in. So I think AI is going to augment the care that we get. And then I want to highlight a point that Dr. Wright made earlier, which is that we really are in the business of health care, but what we have been traditionally doing is sick care. And so the idea of being able to get data when somebody is well, so that you know the signal when they are not well, is the important difference. CardioMEMS is traditionally used for people that are already sick and getting data back on them. We're hoping that AI and all of those sort of tools for digital transformation in healthcare actually help us to get the data for when they are well so we know when they're sick.
Yeah, and of course, the premise, as I mentioned, is that you can keep them well for longer, right? This would all be for naught if we didn't have effective ways, be they biofeedback or medications, to keep people well. But I would submit, as you heard from Dr. Weinberg's talk, that we do have ways of keeping people healthier for a longer period. All of us are going to die, but what you don't want is to die prematurely or die unwell for many years. So you want to live a full, robust life, and I think we have the tools available if we can just apply them.
Great. Do we have any other questions from the audience? We have one over here.
So the question, I'll repeat, was, is there a role for magnesium supplementation? I'll have comments about that, but Nicole, do you want to talk about calcium, magnesium, et cetera, supplements? I will say that, so I'll start. And those of you who heard my salt talk, right? So people bash sodium, but there are some minerals that actually might be helpful. And the two that have most epidemiologic evidence for them are potassium and magnesium, both of which are found in more abundance in plant products. So there are people that argue that one of the benefits of having a more plant-based diet isn't that you're avoiding meat per se, but that you're enhancing the intake of things that might be beneficial, which might include magnesium. Now, when you actually just take normal people like this audience and give them magnesium, there are some things that occur that are beneficial. For example, even a small blood pressure reduction. For any one person, that's probably 1 or 2 millimeters of mercury. It doesn't sound like a lot, but when expressed over the whole population, lowering the blood pressure by a couple millimeters of mercury makes a difference, right? And there are some data about rhythms being better and that kind of thing. So maybe there's a role for magnesium. It's just really hard to prove that in a population.
And I guess what I would also say is there's different kinds of magnesium, and so their absorptive properties are different, and their target organs may ultimately be different. And so I think what I often find when patients take it, if they say they take it and they're feeling better and it treats X, Y, and Z very clearly, then that may be something that's advantageous for them. But if they turn around and tell 5 of their friends, it may not be helpful for them and it may not give the same results. So oftentimes I find that what I'm often recommending to people is that they find some of these, vitamin sources within their foods, because then their absorptive properties are going to be a little bit more targeted and they may find that they feel better. And so I think a lot of the pill supplementation may not necessarily be as good as, eating different foods that have healthier outcomes in terms of the vitamins and minerals. It is on, and I think we're done, unfortunately.
Okay, we're done. Okay, I had one last question for Dr. Weinberg. The microbiome in pregnancy I thought was really interesting, and maybe what would you recommend for women that are coming in for preconception counseling, or maybe in pregnancy might be a great time to capture a population who use OBGYNs as their primary care doctors even before seeing a cardiologist? Anyone on the panel too?
Yeah, I can start on that. Can you hear me now? Yeah. Okay. So I actually think the overlap between our OBGYN colleagues and cardiology is really robust. And especially in our community, I think that we have these very strong linkages because we're starting to identify women that have pregnancy-induced hypertension, preeclampsia, gestational diabetes, and we're understanding that these are women that we need to see within the cardiology office because they will likely have these disorders earlier and it'll be more significant within their overall cardiovascular health. But digging a little bit deeper into this microbiome, I think has been very, very interesting because I think it explains a lot of the imbalances that we may know that we have within our system. We may say something doesn't feel right and I'm not sure what it is. But then as you tease through some of their experiences, you may find, well, they may have, certain imbalances, or they may have certain stressors, or something may not quite be right within their system, and maybe we can identify these people before they get pregnant and get all of the dysbiosis a little bit more straightened out so that they can have a healthier pregnancy and ultimately have healthier offspring. And perhaps that will be better for them in their long term in terms of their cardiovascular health. I think a lot of this data is kind of fresh and new. So in presenting it today, hopefully I'm not telling everybody to start taking probiotics or doing something, unnecessary for their health. But I think it's more to scratch the itch of this chronic inflammation and understanding that there are different linkages to different organ systems, and just because the heart is upstairs and the vaginal flora is downstairs, that they're not overlapping. They're overlapping quite significantly. And I think this study looking at how it affects your offspring, I think that speaks to a whole population of a generation that's being born with different sensitivities and different disease processes that maybe weren't in generations before, and maybe there's a little bit of a propensity for some of these different disease processes because of inflammation.
The other important thing about the gut microbiome is that even when the gut does normally, and you have a normal gut microbiome, many of you have been taught that excess meat ingestion leads to a higher incidence of heart disease. And it's harder, again, to prove or disprove that, but there's a link potentially there, because when you eat a lot of meat, the normal flora in the gut convert some of the substances in meat that are higher quantities in meat than in vegetation, plant products, into substances that may aggravate this irritation, inflammation, et cetera. And our colleagues in Cleveland had been big champions of this, because they measure a blood substance called TMAO, which is a byproduct of bacteria just breaking down normal ingestion of meat. And it turns out that if you have a lot of that circulating, you're much more likely to develop atherosclerosis, coronary disease, heart attacks, et cetera. So it may be that what we thought was bad about meat, that somehow it increased your LDL, et cetera, wasn't the issue at all, that it was the bacteria that we harbor in our gut that are breaking down the meat products into potentially harmful substances that later cause us to have coronary disease.
We have a question here for Dr. Weinberg from Barty.
Oh, hi, this is Joellen, and I have a question for Dr. Weinberg, and perhaps Dr. Itchhaporia or Wright can also tag team. I was wondering, in your talk, you said that a lot of our physical entities are tied back to the heart or grossly integrated with the heart. Who and how do we get to decide what types of diagnostic tools and treatments get implemented first? Is it voice analysis AI? Is it heart monitors? Is it a pacemaker for the lungs versus pacemaker for the heart? I guess how and who gets to decide?
That's a great question. I think a lot of this is information for the practitioners in the community to take a good history, examine the patient, and then decide if they need, whether it's a cardiology consultation or some sort of other specialist consultation, to be able to determine, are these patients that require a heart monitor, are these patients that require some more advanced interventions for their congestive heart failure. So I think good history and good physical exam, and then deciding which practitioners can implement their therapies.
I'll just say that in terms of all of the new technologies that are coming down the pike, cardiology is a very tech-avid field. And we have great cardiovascular science, as you heard from all of the quadruple therapy for heart failure, to when we developed statins to VADs. We've had 70 years of fantastic cardiovascular science, and we've also been a very tech-avid field. And so I think as the new technologies come up, how they're going to integrate into our system is going to be based on the data that it presents. So all these things sound wonderful, but does it work? Does it change the outcome of the patient? And how do you integrate that in terms of really making a difference for the lives of the patient? So I think all of that, until there's significant data, that's not going to get integrated into our system.
Thank you for all the questions. For those of you in the virtual crowd, okay. Okay. All right, one more virtual.
There's one that's very much on target for the conference. So, how should we recruit more women in cardiology and its subspecialties, given the obstacles, for example, family planning, discrimination at work, or in training?
So I think we are already making a lot of progress. First of all, pipeline programs, so going as far as high school students to students coming into college, medical school, and then residency. So I think we're really doing robust pipeline programs, and I think that can be done at the local level, national level. I was talking to the folks from USC and how they're doing some of the similar things that ACC is doing. So I think that will be helpful. As far as the discrimination, and I think there's already a push at a lot of institutions to have change in policies for maternity leave, paternity leave, all of those things that address that. And then I think as we educate and empower women that hear these types of lectures, they can then go and go to their organization or their institution and really advocate for those policies to be integrated and speak up when something is done that is incorrect or inappropriate. So I think the environment is so primed for change that it will continue to change in the positive direction.
Thank you so much.
All right. So welcome back. We hope you're well fed and ready for an afternoon of further information. Over the past year, we've been creating monthly patient spotlights on our social media. The concept is to show our audience that you might think you know what heart disease looks like, but actually you don't. Heart disease looks like you and me. It looks healthy, it looks strong, but there are some surprises lurking below the surface at times. We've had a dramatic response to these people that have opened up their stories to share with us and share with the world, for which we're deeply grateful. We've selected two very special patients to share their stories today. We'll start by sharing a story with you and then introduce the panel to discuss this. Thank you.
I'm Carmen Delia Rodriguez. I'm 71 years old. I live in Los Angeles, originally from New York City. I'm an actor, and I also dabble in real estate investments. And I had a stroke in 2022, and this is my dog, Dookie. I can go back to exactly when I started not to feel myself. It was January 8th of last year, and I noticed that my stride was compromised. It's almost like I had an alignment issue. I would keep going to the left when I was walking my dog, and I was dropping things. I was a little bit confused. I just was so fatigued. I would sleep like for hours. Nothing seemed right, and I started realizing that there's something more serious could be happening to me, and I knew that I was in denial, but I thought that if I just slept as much as possible, I would be okay, because it's probably just a virus, some little quirky thing that happens to somebody who just turned 70. And then on January 12th, I had an audition. This is 4 days later. I'm still having these symptoms. I go into the shower, I come out, I push back my hair, because that's what I usually do, and I looked in the mirror, and I noticed that my face was not symmetrical. Not that it was always perfect, but it was off. So I had an audition, got to put my makeup on. I couldn't do my makeup. I couldn't do my lip line, because this lip here, my side of my face was drooping. Oh, I still have to do my audition. I get in front of the camera, and I do my slate. And when I start saying my name, I hear Porky Pig. I turned off the camera, and I sort of just like crumbled to the floor saying, I'm sick. I really am sick. And I don't know if it's a heart attack or if it's something, maybe it's something I had a bout with cancer a few years ago. And I called a dear friend who is very a patron, and he does a lot of charitable work for St. John's. He goes, just get yourself over there. It's a stroke center. They will take you right away. And they took me and they asked me all sorts of questions. I had a team of 8 people hanging over me, looking into my eyes, asking me silly questions. Who is the President of the United States? What day is it? Et cetera, et cetera. And I was joking and like making believe I didn't know who the President of the United States was. And it was just, I was trying to be light about it, but at the same time, they weren't laughing. They took me into a room and I think I went into a CAT scan, and they pulled me out and they started saying, you are having a stroke and we need to get you into surgery right away. It's, I think they said something to the fact that it could be throbbing in there and I could be close to an aneurysm. And they were able to remove the blockage, the clot, and they brought me back. I ended up in intensive care, and this wonderful team of doctors and some nurses that were just absolutely over the moon wonderful to me. They were trying to assure me that they were going to find out why I had a stroke, because there was my cholesterol was perfect. I did not have AFib. What is going on with this woman? And finally, a day later, Dr. Riza comes in. He said, I'm going to perform what they call a bubble test on you. He came back and he said, you have a very large hole in your heart. And then he went on to explain to me what a PFO is. It's just basically something that we have when we're in our moms, because our lungs are not working, so we have to get the blood directly from our mother to go to each side of the heart. And 20% of the population, it doesn't close. It should close, but it didn't close on me. And it's always been curious to me. I'm 70 years old. Why did it take so long for me to get a clot? I don't know. But I was told that the doctor that was highly recommended from the East Coast was Dr. Peter Pelican, and he was going to be performing the closure. And I was very excited because he was highly, highly recognized and very, very a top guy in his field. After 4 days in the hospital, they sent me to California rehab, where I stayed for about a week, and they worked out some fine-tuning on me, good enough that I was able to go home with a very, very dear friend of mine, and I lived with her in the Palisades until, I was ready to go home on my own. I go to Pacific Heart Institute, and they have a team of doctors there that work with me. And I now have a new neurologist who had asked that, I had told him actually, the reason I told him that I was still dropping things, I was still clumsy, I had fallen a couple of times in 1 month, and he ordered an MRI, which thankfully was good, nothing bad from that. But he also asked that I consider having a permanent, when they say permanent, maybe 5 years, a monitor, a heart monitor, implanted under my skin. And I said okay to that. And this is the part that's kind of kismet to me, is that it was done right exactly on the anniversary of my stroke, that they implanted this heart monitor. And I'm constantly, I feel like I'm being watched. I'm like, my dog has got a tracker, I got a tracker. And, but I feel that that's a good thing, and I feel absolutely very indebted to this team that they took such a special interest with me. When it was found out that I had a PFO, people from the East Coast, other doctors, recommended that there's only one person that should be doing that PFO, and they mentioned Dr. Peter Pelican. I'm going, what's his name again? They got I go, that is so fun. I said, great. I said, I have to ask for him, right? And I didn't have to. They had already put him on the team. So, but I have to do an incredible shout out, and I do not remember their names. the nursing staff at St. John's. I mean, I remember the first night I was there was somebody that was just assigned to me. He would watch me from a window in intensive care, and he told me, he's right off the bat, I'm going to be waking you up every hour. And I'm going, why? He goes, because I have to. On the hour, that cutie would wake me up. And he was absolutely adorable. And I was lucky, I had him for 2 nights while I was in the hospital. But then other nurses came in, and they were as good and very caring. I never, ever had to wait for anybody to have to wait. Some people say, I have to wait, they don't answer my ringing or anything else. That never happened with me. They were on it. I was blessed. I have lots of friends, and they're contemporaries, same age as me. And one thing I tell them, I said, I always thought that I really listened to my body. I do yoga, I've done Pilates, I've done a few things that I think I'm in touch with my body. But there are things that happen to us every day that may be a little odd, and we just basically forget about it. I would say to any woman out there who is experiencing a lot of odd things happening in one day, headache, fatigue, balance issues, coordination, that's a big one. Maybe you cannot speak properly and you just say, oh, I'm tongue-tied. Are you tongue-tied? I would say in a minute, I would just go. If I cannot get an appointment with my internist, go to ER. I mean, really, I would say just go to ER, period. I mean, what is the worst thing that'll happen? You'll feel embarrassed and they're not going to do that. They're going to say, listen, you did the right thing. There are signs, and they're not all the same. I had signs in which I really thought I had an inner ear issue. And in fact, I was having a massive stroke. So I would say that even though it sounds like, oh, this is nothing, because women tend to do that, it could be something. And it could be something that could basically kill you. One thing I do have to say about the stroke, and when I think about it and I think what I've been through, and that I'm sort of like a miracle, because if I would have gone to sleep instead of having that audition on January 12th, I may not be here telling the story. That's how close I got. But so many wonderful things have come out of the stroke, and they're within me. I feel that I am kinder. I am more clear about things. I know now how to ask instead of feeling awkward about asking. I'm a 71-year-old woman. I've been single for many years. I should be able to handle myself, but no, now I ask. And I don't know, I feel so much better and happier than I ever felt before. I'm not making any more money than I ever made before. I don't have more friends. I actually have less friends. I have great doctors that I could call and ask things about, and I have a family, and some of them have come back to me. So I kind of think that the stroke happened for a reason, and I don't know what the reasons is, but I think I call it the magic of life, and that's how I approach life right now. I'm clear, and I really sincerely have never been happier than I have been in the past few months.
Wow. Let's introduce our panel now. First and foremost, the incredible Carmen Delia Rodriguez. Our hematologist, Dr. Grace Chang. and interventional cardiologist Dr. Peter Pelican, and nurse practitioner Mariana Marquez. So if it's okay, Peter, I'll start with you. Dr. Pelican, excuse me. Carmen, you described the reason that fetuses have a PFO very nicely. Would you be able to show us, Dr. Pelican, the anatomy and how this can result in a stroke? And if we could have that image pulled up.
Yes, but I have a question first. How do you get the dog to not move for all that period of time? That is training.
He's a good boy.
Yeah. I think you can just talk.
Okay.
Could we have the image?
The question being?
The question is, how did you have a stroke?
I had a stroke because I had a PFO, which I did not know anything about until I was in the hospital, and I was diagnosed by my neurologist who did what they call a bubble test. And I just thought that I was going to probably have more strokes. You can catastrophize a lot when you're in the hospital and people are constantly watching you. But once I found out that it was indeed something, the PFO, I thought that, well, thank God, there's something there that might be able to fix, and maybe I can go ahead and get back my life.
So actually, you described the PFO quite well. So we all start out as fish. We're living underwater in the uterus. There is no air in there. And the oxygenation of your blood comes through the mother's placenta. That oxygenates your blood. So you don't need to have a lot of blood flow to the lungs. Blood that returns to the right side of the heart, which when you're an adult or after birth, would go from the right side of the heart to the lungs, just goes directly across a little flap valve called a patent foramen ovale, which is just confusing Latin for an open oval-shaped hole. And you can see that on the right side of the diagram there. When you're born and take that first breath as the doctor slaps your behind, you gasp in, and as Dr. Wright said, the pressures inside your chest change when you breathe in, breathe out. That flap valve is pushed shut because there's more pressure on one side of the heart than the other. For the next 6 weeks or so, it can open and close if you laugh, or I guess you're not laughing as a baby, but if you're throwing up or crying or anything. And in about 80% of people, that ends up sealing completely shut. And in about 20 or 25% of people, it never closes. So through your adult life, if you bear down, like you're trying to have a very hard bowel movement, or if you laugh or grunt or lift a heavy weight, which alters the pressure relationships inside your chest and abdomen, that thing can get pushed open. And if a blood clot happens to be in your right atrium, it would normally go out to your lungs and get caught in the lungs. It will go across into the left side of the circulation, and the biggest next artery is the arteries going up to your brain. So when that clot lodges in the brain, that's a stroke.
Here's that next image of what Dr. Pelican's speaking about.
I'm going to show you a picture of him. So if you look at the upper left-hand screen, there's an arrow at an artery that is abruptly cut off, and that is a clot. This isn't Carmen's brain, but it is actually the same artery that was occluded in her brain, the middle cerebral artery. And then after the neurointerventionalists, who are, in my opinion, the coolest people in the hospital, we interventional cardiologists think we're pretty cool, but these guys, the stuff that we do in one or two arteries, they can do in any artery in the brain. It's pretty impressive what they can do. Speak louder. But on the bottom screen, the same arrow is pointing at that artery after the clot has been removed from the artery and allows blood flow to return. So Ms. Rodriguez is very lucky. She gave a plug for early presentation to the emergency room. She was late enough that she was too late for a intravenous clot-busting drug, and frequently people who present late do not have the miraculous recovery that she had. So early presentation is good, but if you can't have the intravenous drug, you can go to the cath lab and the neurointerventional specialist can get a catheter into your brain, suck that clot out of there, and reestablish blood flow. And in many, many cases, then all of the signs and symptoms of a stroke go away.
And then we have a video of how that PFO is closed. Would you be able to talk us through your procedure once that loads up?
So that was the acute treatment. The chronic preventative therapy is then to put a closure plug in. There's a Gore exhibit back there if you want. I think they should have some of these plugs if you want to go by there and hold it. So I just took this. There are multiple companies that make this. I'm not trying to be a Gore advertiser, but there's a little catheter placed across the hole in the heart, and this is sort of a double disc gizmo, for lack of a better word, and it's pulled up against the wall between the two sides of the heart, and the two discs are deployed, covering the hole. You push a little bit, make sure it's really left in place well, and then let go of it, and over the next 3 months or so, that will be completely covered by your heart's tissue, and there will be no more ability of a clot to go from the right side to the left side of the heart. So fabulous stroke preventer.
So Ms. Rodriguez mentioned some other causes of stroke that she was evaluated for: atrial fibrillation, high cholesterol. So if 25% of us in this room have a PFO, what evaluation do you do to decide that you should close it or not?
Well, the most important is you've had a stroke. So if everyone who had one of these had a stroke, there'd be, whatever it is, 75 million strokes in America this year. So the big, if you happen to have an echocardiogram that says, I have a PFO, and you're completely asymptomatic, never had a stroke, there's no reason to close that, and it's definitely not FDA approved for closure. But if you've had a stroke, and you have a PFO, and there is no other cause of a stroke, like atrial fibrillation, like a blockage in the artery going up to your brain and your neck, or a blockage inside an artery in your brain, then we're left with circumstantial evidence that this was the cause of the stroke. It's not proof, but there's fairly robust research data that closing this will reduce your risk of having another event. And then in that context, I don't know if I'm out of order, but we always get Dr. Chang or one of her colleagues who's a hematologist, because some people's blood is extra likely to form clots. It's the opposite of hemophilia, where you're extra likely to bleed. But if you have the PFO and a stroke and thrombophilia or hypercoagulable state, which I'll just stop there and say how important that is in the thought process of how to treat these patients.
Great, thank you. Yeah, Dr. Chang, what type of evaluation do you do in stroke patients who've had this type of paradoxical embolus?
Great transition. Thank you, Peter. Grace Chang. I'm one of the hematologists at Providence St. John's. And so we had the privilege to take care of Carmen through our team. And so to answer your question, besides a comprehensive cardiac exam from Pacific Heart team, I usually sit down with the patient and I ask her what is her personal history, whether she's had a prior stroke before or, blood clots, whether she's on any hormone replacement. I talk to her about her family history, whether, there's any family history of blood clots or any family history of cancer. All of these can increase the risk of blood clots. And then ultimately I would do a hypercoagulable workup through the blood to see if there's any prothrombotic etiologies, thickness in her blood. So the causes of hypercoagulable state is one, it can be hereditary. The most common cause is factor V Leiden. A second in line is prothrombin mutation. So these are things that you are born with, it's passed along in the genes from your parents. Other causes of hypercoagulable state is acquired cause, which is your lifestyle, smoking, hormone replacement usage, your weight, your lifestyle can affect your prothrombotic risks. And then lastly would be underlying malignancy. So it's highly recommended to do yearly age-appropriate screening when you're older than 50 to make sure that there's not any kind of occult malignancy that's occurring that's causing your blood to be thicker than normal. Now with Carmen, she did have a hypercoagulable workup done, and she was found to have an elevated factor VIII. And so an elevated factor VIII it's a protein that's made in the liver, and what it does, the body uses it to form clots when it's necessary in the setting of bleed or in the setting of acute inflammation. And so an elevated factor VIII gets triggered. It triggers a coagulation cascade in your body, and it tells the body to form more clots. And so, interestingly, factor VIII, the role of factor VIII in this setting was initially found in patients who are hemophiliacs with low factor VIII, and they were associated to have low coronary events. So this was how it was originally found. And so in terms of elevated factor VIII, in the adult population, if you do have an elevated factor VIII, you're twice more likely to have a thrombotic event, stroke, compared to your peers with normal or lower factor VIII. And so it's something to be cognizant of. With Carmen, her factor VIII was elevated, and so in her situation, on repeat, so factor VIII can be elevated in the setting of an acute inflammation, infection, or if you had injury, or if you have underlying autoimmune disease, your factor VIII can be elevated. So we usually kind of monitor that. If it trends down, then we think that it's related to a pro-inflammatory event that will resolve on its own. But if it stays persistently elevated, then we kind of talk to her about possibilities of anticoagulation long term.
Great, thank you. And then Mariana, Carmen described her symptoms so clearly. It was great. At St. John's, we have code stroke. Would you just tell us a little bit about why we have a label code stroke, and then what are possible signs of stroke that you look for when you're evaluating patients?
Thank you. My name is Mariana. I'm an ICU nurse at St. John's, where Carmen received her care. So you can thank some of these nurses in the front here, some ICU nurses who took care of you, I'm sure. But code stroke is basically early detection for any type of neurological event. I think we've all seen in the layman's world about BFAST, the acronym that indicates signs of stroke. And Carmen so articulately expressed her symptoms. And so B being for balance, she talked about being, her stride was off. She felt a little off balance. E being for eyes, your eyesight, double vision, blurry vision. F being for your face. Carmen talked about her face was droopy. She couldn't put on her lip liner that morning. A being for arms. Sometimes our arms can be either numb or drifty. We know that a lot of patients who have stroke symptoms might have weakness on one side or the other. S being for speech being off. She said Porky Pig came out when she was supposed to say her name. And also an indication, a speech would also be an indicator of whether or not you're somewhat confused or disoriented, an altered level of mental status. And then lastly, time. Time being of essence for early detection so that we can intervene and have the best case outcome for a patient. So those are the things that we look at when we are trying to determine whether or not someone's having a stroke. And then subsequently in the ICU, I think you talked a little bit about being woken up every hour. So after her interventions in the acute period, continuing to monitor our patients for signs of neurological deterioration. And unfortunately, we have to wake patients up even when they're sleeping or interrupt visits with their family to do a neurological exam and basically looking for those same stroke signs. We'll ask silly questions like, who's the president and what's your name? We're evaluating for your speech. We're evaluating for if you are having some change in your cognition. Are you having numbness or tingling in your face? Are you able to raise your hands and keep them up and not drift down, which would indicate some type of change in your balance? And so that we as nurses can then advocate for our patients for early detection for some type of change after a stroke and let the team know, and they can determine whether or not there needs to be further imaging or interventions that could provide a best outcome for our patients.
Great, that's helpful. And then, Ms. Rodriguez, you have undoubtedly saved lives in just the message you've sent about getting checked out and getting checked out quickly. So that's incredibly helpful. Would you just tell us a little bit about your recovery and things that you found were helpful through rehab, physical therapy, or things that we should know that were more challenging and you felt could be done differently?
I remember it so clearly. When I was discharged from the hospital and yet did not have the hole in my heart repaired, I went immediately to rehab. And it was surreal because I couldn't really walk. I needed assistance. My alignment was still off. My speech was, I could barely understand myself. I'm from New York. It's right. I am from New York. Anyway, but nonetheless, I was in rehab for a week, and then I stayed with my friend, and then I went home for 2 weeks before having my PFO repaired. It was very frightening because I would get to bed at night and think that because I'm so vulnerable right now, I said, am I going to die in my sleep? So I had to have work my head on that. And I was always prepared of probably dying in my sleep because if I had a stroke during the day, I could call somebody. I could feel it. But I heard people can die in their sleep, and I was very vulnerable because I kept visualizing this hole in my heart. But after it was repaired, that's when I started really applying myself and reading as much as I possibly could, and noticing that I did have some effects from it, and they're still there. I still drop things. My alignment is not perfect. I can drive well, but it's had a lot to do with my starting to do meditation and realizing to live in the moment. And I think that for me personally, other people can do other things, but to me, to live in the moment and to know who the circle of loved ones are has basically allowed me to turn the page on this. And I know probably that I am as healthy as can be. I am extremely supervised and observed by the doctors. I have now a monitor, like I call it my low jack, and I just feel that I'm good for another 25 years. Let's say that.
Nice. Dr. Pelican, why don't you close the PFO right after the neurointerventionalists are done with their procedure?
So there really isn't good data on when to close it, but the concern is that the blood clot that went into the heart typically comes from a vein somewhere in the legs or the belly or the pelvis. We don't usually have the ability to see it because it may just be sort of up against the wall of a vessel. And if you put a catheter in to try to fix the PFO and you knock the blood clot loose, you're going to cause another stroke. So depending on what Dr. Chang finds, we decide what sort of anticoagulation to use. But it's my belief, and I'm using the word belief because it's not science, that if you wait 4 to 6 weeks of blood thinning, if there was a clot in there that you might dislodge, it will hopefully be dissolved by the time you do the procedure. So that's the reason for waiting. It's not to torture the patient.
If anyone from the audience had any questions before I go on for our panel.
So 25% of the population has a PFO. Is there any correlation with anything else in the body that the reason it didn't close? I mean, has there been any studies to find out, or is it just a random thing?
As far as I know, it's random.
Okay.
Maybe Dr. Wright knows the answer because he knows everything, but.
As far as correlation, though, I know there is a correlation not with why you'd have it, but with migraines. And years ago, there was research looking at closing PFOs for patients with migraines. What I recall is it didn't actually improve the migraine, though. So. Oh, really?
So it's
See,
it's an interesting topic. I'm going to talk about one of Dr. Wright's patients actually who had a stroke, but also had been plagued by severe migraines, and we closed the PFO, and her migraines went away. So that had been found. The research studies that were done, I'm sure Dr. Wright's going to disagree with me, but the ones that I've read lately, there hasn't been corroboration that closing it treats migraines. Maybe you've seen more recent ones.
Yeah, so the latest iteration of that is if you have aura, that is the visual things that precede the headache, then in fact closing the hole, whether it's a patent foramen ovale or an atrial septal defect, which is basically a larger patent foramen ovale, the migraines, the frequency of migraines goes way down. So the marker of benefit is if you have visual aura. If you just have headaches without aura, then the studies do not reveal that there's a benefit of closure of the hole.
Any other questions? I have another question for Dr. Chang, kind of. I don't know if there's any research for this, but based on that, if you have a patient with migraines with aura and some known familial risk for clotting, how do you decide? Do you put them, or does the aura or migraine factor into your anticoagulation decision?
There's really no study for that, but I would definitely be on, on very strict lookout. I'd definitely work her up for hypercoagulable state. And, I'm going to be looking, depending on her age, if it's, older than 50, I would be looking out for anything that we'd be missing, any kind of occult malignancy. So, doctors never stop trying. We never say no. We want to, try to figure out what's the cause, and we're with the patient. If there's anything that the patient's feeling, we're going to be looking and trying to find out what's going on. So if the patient continues to have headaches, I'll be working with the neurologist, of course, to see if there's anything that that could be underlying. There's, besides factor VIII, there's also factor IX. There's other procoagulants that we could look for besides the initial screen. There's also antiphospholipid syndrome. That is an acquired form of hypercoagulable state. It's an autoimmune-associated syndrome. In these patients, they can get arterial as well as venous clots. So there's a lot of different etiologies that can cause the blood to be thick and for us to initiate anticoagulation therapy.
Yeah, I'll say one more thing about the aura. So if you have aura with migraines, then you have a 50% chance of having a patent foramen ovale, not a 20% or 25. So there's a clear connection. And secondly, we're not sure what causes the aura. We don't actually think it's microclots. It may be substances, chemicals, if you will, that normally would be filtered out by the lungs, but that make it through the hole and cause whatever migraines are caused by. There's still a lot of controversy about what exactly a migraine is. But the modern thinking is that it's noxious substances that lead to the brains having this typical funny vision, followed in many people by headache.
I'll ask another question for Mariana. Ms. Rodriguez had an incredible recovery. What's the determining factor? It sounds like a pretty short course in the hospital, considering how you determine when they're ready to leave the ICU, when they go to rehab or higher intensity nursing facility. What sorts of things are you looking for in their recovery?
So when a patient comes to the hospital with a stroke following the initial intervention or treatment, there is a whole protocol or order set, for lack of a better word, for the patient to go through during their stay. So just besides being in the ICU, which is really just a higher level of monitoring that's necessary after, in Ms. Rodriguez's case, she had a thrombectomy, or if you had a thrombolytic, like Dr. Pelican talked about, like TNK or TPA, where you would need the frequent monitoring after that period of time. Usually if patients are stable hemodynamically, their blood pressure, their heart rate, everything is stable, then you're ready to leave the ICU. Perhaps not leave the hospital without physical therapy, occupational therapy, speech therapy, and those modalities will then determine when the patient is ready to move on, whether it be home or to another facility like California Rehab or a nursing facility for safety purposes, to make sure that the patient is safe and well supported by the extended team that's will facilitate long-term recovery for the patient.
I'll ask one more question then for Dr. Chang and or Dr. Pelican. So if you have a patient who had an echocardiogram, incidentally found PFO, no known hypercoagulable state, no history of stroke, do you recommend anything for them when they call you and say, what does this mean?
Let's make it even worse. Let's just say you're a, I don't know, compulsive paranoid cardiologist. I don't know any like that. And you said, okay, you have a PFO. Why don't we get a hypercoagulability workup? And you're hypercoagulable and you've never had a stroke. Do you close the PFO? And there isn't, I mean, first of all, Medicare or Blue Cross will not pay for it. So that's one issue, because the insurance companies, this is an expensive procedure. That, I don't know, those guys back there can tell you what the device costs, but it's tens of thousands of dollars. And the insurance companies don't want to pay it. But also from a medical standpoint, there isn't a real good answer as to whether that person ought to have a PFO closure or not. If they're truly hypercoagulable, then Dr. Chang can tell you whether they should be anticoagulated or not. But there isn't a good answer. It's a sort of a problem gray area.
So essentially then I would take that patient, the neurotic cardiologist, and I would calm him down and I'd put him on anticoagulation. And then hopefully he does not develop a stroke. And but if you wanted to pay out of pocket, then Pacific Heart may consider.
Would you do a hypercoagulable workup in a patient with a PFO and no stroke? And no family history of clotting disorder?
I don't think, is he Medicare? I don't think Medicare would pay for it. It would have to be, out of pocket. But but it'll have to be a discussion between the patient, and I would start with malignancy workup if it's an older patient population. That would be the most likely possibility.
I'm sorry, but if they've never had a clot, some doctor somewhere ordered an echo and they saw a PFO, you wouldn't ordinarily just get a hypercoagulability workup. You would just say, 75 million people have this, forget about it.
Yeah.
Yeah, but Peter, it also depends on the size of the patent foramen ovale. So it's not a yes or no, do you have a PFO? It's also how big is the PFO and how large is the blood volume going from the right heart to the left heart. So one way through this conundrum, if somebody has a large patent foramen ovale with a large amount of shunting that goes from the right heart to the left heart, one can seek evidence of prior embolic events. As an example, if they had a brain MRI and they had already a stroke of which they were unaware, and lots of strokes people do not know they've had, they say, well, I'm imbalanced and I just thought it was old age, that kind of thing. So if somebody has a large PFO and imaging evidence of a stroke, then in my patient population, I would refer them to Dr. Pelican for consideration of closure of the PFO.
Definitely. You'd have to work closely with a neurologist, and, cryptogenic strokes, strokes where you don't have any symptoms, definitely should be worked up. So it's a multidisciplinary team of doctors who's going to be, handling the case and taking care of the patient and figuring out what's the cause and what is the best management going forward.
Any other questions? Great. Well, thank you so much to all of the panelists, especially to Carmen Rodriguez, for telling her story today. After the next video, we'll ask the next panel to come up to showcase another story to tug at your heartstrings.
My name is Trisha Drumlall. I'm 50 years old. I'm a physician assistant, and I was diagnosed with cardiomyopathy with my second child. Before I got pregnant, I was pretty healthy. I had a few rheumatological issues underlying, but very healthy. Didn't have any heart issues that I was aware of, and was just a full-time working mom and wife and daughter, and just busy doing what I did. I was pregnant with my second child, my daughter. My first pregnancy was very uneventful, perfect, no problems. Second pregnancy had some more issues. Towards the end, I developed preeclampsia, and I ended up having to have a C-section at about 37 weeks because I was starting to develop high blood pressure, and I had some protein in my urine, which can be a problem. And so at 37 weeks, they said that we need to do a C-section. During that time of my C-section, a significant thing that happened was I was in the OR and feeling like I'm suddenly going to die. My blood pressure dropped to 60/40, and I was like, what is going on? Luckily, the anesthesiologist was smart enough to give me some pressors to bring my blood pressure back up, but that was kind of the first sign that something was wrong, but I didn't know at that point what that was. Lead me to coming home 4 weeks later, trying to live my life, do what I normally do, have a son who's 3, now a baby, feeling like more anxious, feeling a little more short of breath, not kind of sleeping great, having to sleep sitting up, and being the medical professional that I am, I'm a physician assistant. I worked in the ER for 20 years. I was starting to listen to my own lungs, taking care of myself, thinking I'm just anxious, I'm tired, there's nothing wrong with me, can continue to put it off. And then one day I was coming home from the store and I had groceries and I was huffing and puffing carrying groceries from my car into my house, and I had 2 steps. So one of my colleagues from the ER called me that day, and I was so breathless with talking. He was like, there's something wrong, are you okay? And I was like, well, I'm probably anemic, I'm probably stressed, I might have a blood clot, I don't know, I'm not going to the ER, I work there, I don't need to go. And he was like, listen, there are rare occasions when women who've just had babies can have cardiomyopathy. And I was like, there's no way I have cardiomyopathy. I've worked 20 years, or 15, 16 years at the time, in the ER. I've never seen that happen, and there's no way I have it. And he was like, please go see somebody. So I actually decided to call my doctor. I didn't go to the ER. I called my primary care doctor, and I was like, I need to come in and be seen. Went and saw her. She did an x-ray and EKG and basically said, you have to go to the emergency room because it looks like you're in heart failure. And I was like, what? So we then proceeded to go to the hospital, and we went to the ER. And then one of the echo techs who I had worked with for many years was there, and he was doing my echocardiogram, and they're not supposed to say what they see. We won't tell who this was. No, but, and I was like, what's my ejection fraction? What is it? And he was looking at me like, I don't want to tell you. And I was like, what is it? And he was like, it's like 20 to 25, which is not good. Normal is 60 or above. And so I immediately went into panic. I, thought, I'm not going to make this. I'm going to possibly die. And called my sister and was like, I need you to take care of my children if something happens to me. It was a pretty eye-opening moment. And then I was admitted to the hospital. I was up on the cardiac floor for the next week, and they were taking fluid off and giving me medication. That preceded the next 9 months of recovery, trying to, get into why this was going on and what was happening. And then took medications, saw my cardiologist and some other specialists. But it was pretty shocking. It was not what I expected. So I ended up, after about 9 months, I didn't work in the ER. I took some time off, recovered, didn't do a lot other than take medication. And at the time I was 41, and I was told by a lot of the cardiologists and people that I saw that, your heart can come back and go back to normal. It's not uncommon that you can, regain your full function. There are times it doesn't happen, but I was lucky that I ended up getting my full function back. So around 2016, end of that year, I stopped medication. And then from 2017 to 2019, I was fine. I was back to work, working full-time in the ER, 12-hour shifts, full-time, 2 young kids, daughter. I had some elderly parents that were kind of declining in their health. I was taking care of them. So in 2019, everything kind of came crashing down where, again, just busy, working, mom, daughter, and then one day I didn't feel well, and again, kind of busy life, trying to, do things, going on vacation, putting things off, and I just was, again, walking up some stairs, carrying some bags, and I was like, this is suddenly reminiscent, I'm suddenly short of breath. Why am I short of breath again? And of course, I called the ER and I spoke with the same doctor that I had spoken to, convinced me to go to the ER, 3 years earlier. And I was like, I just don't feel good. And I'm short of breath again. And he was like, you need to come in. And I'm like, I'm going on vacation tomorrow. I don't think I can come in. He's like, no, you need to come in. So again, I had been putting it off, and I basically went in to the ER. I had a new EKG finding at the time, which was like a right bundle branch block, which I hadn't had before. And then they repeated an echo. And again, this different echo tech, different one, kind of gave a preliminary report, which they do. It's not uncommon what they see, to the doctor. And then it was like, what's my ejection fraction? And this tech was like, oh, it looks good. Like, it's normal. I was like, great. So then the doctor called my cardiologist and, was like, well, she's going to go on vacation. Does it seem okay? It seems fine. Her EF is fine. She can go. The next day I went on a Disney cruise with my family and then 2 other families, and I did not feel well, and I was short of breath again, and another episode where I just felt like I'm not going to make it. I don't know what's going on. And then 2 days later, we get into port, and my phone starts tinging, binging off the, edge, and it's my cardiologist calling saying, you have to come home. Your ejection fraction is like 30 or 35. So I left my family on the cruise in Cabo. I came back home by myself, and then I ended up having a reoccurrence of cardiomyopathy. So then proceeded in a 2-year journey of, going to see other cardiologists. Ended up coming and meeting Nicole Weinberg to be my new cardiologist, because she's the best cardiologist there is. And so anyway, and then from there I ended up doing some cardiac rehab. So I did that. I did physical rehab, and then I didn't come back as quickly as I did the first time. I was on medications. My blood pressure was dropping constantly. I was lightheaded. I was dizzy. I didn't feel well, and I had all these other, extreme circumstances in my life happening at the time. I just kept putting off dealing with myself because I was dealing with everybody else. There was a lot of pressure for me to go back to work for my job and get back into the ER. And I was really having a struggle with, of course I have to work. I can't not work. I have my insurance through them. I need to go back to work. And then right a week before I was supposed to go back, I was picking my kids up from school, and I had an event where my heart rate went up into the 160s, 190s. I almost passed out. They had to bring me from the school where I was picking my children up, where I thought I'm gonna pass away and drop dead on my kids' schoolyard. They took me from an ambulance to the hospital. I was readmitted and then stabilized. And then at that point, my cardiologist at the time came in and was like, you need to just let it go and stop worrying about your job and stop worrying about your insurance and stop worrying about everything. You need to focus on yourself, because the 6 months prior of my reoccurrence, I was dealing with everything else, and my parents and my kids. And she's like, you just got to let it go. And so at that moment, I was like, okay, you're right. And I finally let it go. And I actually walked away and started to focus on myself. And then that's when I actually started the cardiac rehab and started to really deal with myself and do what I needed to do. And then after another probably 6 months of that, my ejection fraction still was in the low 30s. And I was having bouts where, again, I just wasn't feeling well. And then I was terrified, and I thought, I'm going to die. Like, I could drop dead of an arrhythmia, and I have 2 young kids. And so that's when Nicole Weinberg was like, let's have you see somebody, Dr. Vanderzee, who's also amazing, and let's see if you qualify for a defibrillator. And so at that time, it was like, if it was something that could give me any kind of a life-saving option, I wanted to do it. So in last year or 2 years ago, I ended up having a defibrillator put in. And since then my heart rate, my ejection fraction came back up, and I feel like things have gotten stabilized with my medications, and then things have gotten kind of back to baseline. And then now I went into a different form of medicine. I now work with Ernie Prudente at Westside Internal Medicine in kind of a day job and less stress, and I couldn't be happier. So things are better now. One piece of advice that I would give to any young woman who sees themselves having a child down the line would be, for me, I ended up, when I was 39 or 40, I ended up going to a cardiologist just to get like a baseline, synopsis of myself. I actually was having a little bit of some stress and wasn't really sure if it was heart related. So I thought, I'm going to be 40. I'm just going to go see a cardiologist and get a baseline. And that was probably one of the best things I did. because the cardiologist at the time did an EKG, an echocardiogram, and had all of my baseline with what was normal for me. And so when it came time, and a year or 2 years later, when I was in the ER and my ejection fraction was 20-25, they could look back, to 2 years prior and see that my normal ejection fraction is normally 60. So I think it's really helpful. And, again, as women and as any, patient, they don't go see a cardiologist until they're having a problem, or they're, older, or they're having chest pain and something's not right. I just feel for myself, and again, it's not always medically indicated for everyone, but I think if you think you're going to have a child and there is a risk of any kind of heart issue, have a baseline cardiology exam beforehand. That could be very helpful. Since I was little, I wanted to go into medicine, and I was a little girl, and my dream was to take care of people. That dream came true, and I was a caretaker, and then I wanted to have a family, so the whole picture of, living the dream, having it all, I had, and it was amazing. But again, as a caretaker and as a medical professional, we tend to forget and we don't take care of ourselves. So that was the biggest lesson for me, was that I had to learn to take care of myself and put myself first, because I now had children of my own that had their own dreams, that were going to live that dream and fulfill that. And I wanted to be there to see it and to be part of it. And so that means I had to take care of myself.
So I'd like to invite all of the panelists for the second panel up at this time. Thank you so much, Tricia, for sharing that unbelievable story with us. It touches on so many of the issues that we've been talking about already today, in terms of cardiovascular risk factors, those that are more specific, non-traditional, rheumatologics, more specific to women and pregnancy, and then also the journey that we are, all take as professionals, taking care of ourselves and other people at the same time. It's a privilege to share this with us, and thank you so much. I think you've met several of our panelists. I did want to take the opportunity, Jodine, if you could just introduce yourself and tell us what you do at St. John's.
Sure. Hi, everybody. My name is Jodine Strelli. I am currently the clinical nurse educator for the Women's Health Departments. That's labor and delivery, the postpartum unit, and the neonatal intensive care unit.
Okay, thank you, and thank you everyone for joining us. So if I could actually start with you. So Tricia, your story is a little bit unusual in the sense that we didn't know that the only problem we knew that you had at the time that you came in pregnant or about to deliver was the preeclampsia. We didn't know about the peripartum cardiomyopathy until several days later. But if you could tell us, Jodine, how do you approach patients that come in and are higher risk, especially from the maternal side?
Sure. So obviously, best case scenario is that we know a patient has a high risk factor. So, for example, preeclampsia, we see so often nowadays in our pregnant population that sometimes we kind of forget on our labor side that is a high risk condition because we see it so often. So that's not one that we would necessarily need a lot of prior knowledge of, because we have such great policies and procedures on how to take care of our patients with preeclampsia. Now, there are other high-risk conditions that we may not see very often. So, for example, if we knew that you had cardiomyopathy, then that would be something that we would plan for. We have a great system of interprofessional collaboration with our doctors. We have meetings with cardiologists, hematologists, oncologists, whoever we need for that patient for her delivery. we have sessions of meetings, making sure that we have all the equipment, all the personnel that we need, and also to make sure that we are the appropriate place for that delivery. We are humble enough to say if we can't take care of that patient, if we're not the right place, that patient needs to be transferred out. But we are a great team. We are highly trained and highly specialized to take care of many of our high-risk populations. So yeah, if we can plan for it, we will. If we can't, then we're going to fall back on our training.
Great, thank you. And then Tricia, could you tell us a little bit what it was like in the immediate postpartum, and then you were quickly rehospitalized on the cardiac unit. Can you tell us a little bit about what that experience was like?
Yes, so immediately postpartum, it was great. I was up on the OB floor, they were awesome, no issues really, and then got home, and it was about 4 weeks later that this all happened, and then when I was brought up into the ER and I was admitted, then they brought me up to CCU, or the cardiac unit, and that was difficult because I had a daughter who was 4 weeks old, and at the time was breastfeeding a little bit, not that much, but it was suddenly like you can't breastfeed anymore because you're going to be put on these heart medications, and then she can't really stay with you. She needs to go home. So I was alone. My husband had to stay home with my daughter and our son. My parents were around, but they were with him, helping him. But being up on the cardiac floor, the nurses are amazing, and I have to do a little shout out to Nikki out there, who was my nurse up on CCU, and you all may know Nikki, and she's amazing herself, but I'll never forget just her taking care of me up there was just a blessing, because she was my angel who really held my hand, got me through it, brought me like mango slushies one day on her way to work, and she was just amazing, and that was the best part of being up there, was having her, and then the other staff when she wasn't there. So because my parents, and they would bring my daughter by once or twice in the period of time I was there, but I just was kind of alone, so that was awful. But the CCU staff and Nikki made it bearable. So.
Thank you. And then, Dr. Weinberg or Dr. Itchhaporia, could you tell us when a patient comes in who has peripartum cardiomyopathy, how do you approach the treatment and any other workup?
I would say initially a lot of it is kind of isolating the patient's risk factors for disease, like how did they end up in this situation, what was maybe the cause of their cardiomyopathy, and so you try to peel back the layers and do your best to make sure that the patient is stable, make sure that their volume status is stable. If they're in congestive heart failure, get some of the fluid off. And then we make sure that they're on medications that it hopefully will work in concert together to help raise the ejection fraction and strengthen the heart. And it sounds like that's exactly what happened with Tricia initially. She was identified early, she was treated aggressively, she was put on really good medication therapy, and she had resolution of her drop in her ejection fraction. And so, and that was sustained for quite some time, also because she had done her due diligence ahead of time. She knew what her risk factors were. She had knowledge of what her cardiovascular risks were before coming in, and she had been quite healthy. So I think that's a lot of our initial assessments of a patient like Tricia.
And so our understanding has changed a lot in the last 10 years in terms of cardiovascular conditions in pregnancy being a risk factor for or predictive of issues that can come up later in life. What are the most important of those, and what do we understand about why that is?
Well, we know that pregnancy-related complications such as preeclampsia, gestational hypertension, gestational diabetes, all of those are those patients that have that, they're in the higher risk group for long-term developing cardiovascular disease. So in a way, you identify those patients, and what you want to do is long-term follow them and make sure that you modify their risk factors as best as you can. So I think nowadays there's so many women followed by OBGYNs as the primary care physicians that you want to make sure you have those conversations with your OBGYN colleagues to identify those patients that are higher risk and make sure they're in the cardiac care system, so to speak, so that we can modify those risk factors.
Great.
So I was going to say, the other kind of interesting thing about Trisha's case as it relates to when she came to me and had other care beforehand was the dynamic in terms of our treatments of congestive heart failure are changing. There's new drug therapies that are coming out. So I had the benefit of knowing your history because we friendly beforehand. And so maybe I knew a little bit of her journey. But then when she had come to me initially, we had newer drugs that were on the market. And so I had kind of a good confidence that we were going to be able to get things rectified because we had newer, powerful drugs. So I knew from before that she did well on her drug therapy. I knew some of the agents that were out that were newer for congestive heart failure. And so instituting the therapy and making sure that we got you to goal doses of the therapy was, obviously a real blessing that we had. The other thing that was interesting with your case was I think your heart racing issues were a bit new when you came to me. And so I remember like a smile during, everything's fine, you're going to be fine. And I remember as soon as she walked out of the room, I was like, Serena, you've got to get an AICD in this gal right away. And so I don't know if this is a time to punt back to you, but I also felt like, the dynamic of an AICD for a gal who has a waxing and waning cardiomyopathy where her ejection fraction may drop and rise and drop and rise, knowing what that is for somebody in her condition, it was an important adjunctive therapy.
Can I make one other comment? I think the other thing that's changing is that there is cardiomyopathy that's recovered, and I think we think about those patients as still needing long-term therapy. Whereas in the past, if they recovered, they take you off the medications, and now I don't think that's the thinking. The thinking is that patients that have recovered still should be on those medications just because of that chance of rebound.
Yeah, and I think, right, it might have been a harder discussion for us if the ejection fraction was fully normal at the time. We would still have had, had the conversation about residual risk. But at the time, I think your ejection fraction was in the 35% range. You were having symptoms, clearly fell into a category of what we call primary prevention, where the risk is high enough to justify a not insignificant procedure. And the patient experience obviously varies dramatically. Some patients will say, I don't want anything, anything put in my body no matter what. And then you're on the other side of the spectrum saying, hey, I would like the maximum protection I can. I don't know if you wanted to comment a little bit at what the experience has been like having an ICD or what that has any issues.
I mean, the experience, it's been fine. I mean, I went in and had it done, and she put it in. She did a great job. And, I mean, I really don't even really know it's there. The only time I think about it is if I'm at an airport or an event, and I'm like, I can't go through that thing. I've got to walk around. But that's it. I mean, it doesn't bother me, but it does make me feel protected. And I went through months of like that. My blood pressure would drop really low. I was dizzy. I'd be on the bathroom floor in the middle of the night because I felt lightheaded and dizzy. And my husband right there, and I'm just like, oh my God, I don't, like, is this it? Is this the moment? Like, it just was always terrifying. And I tried not to be too much of a worrier, and I think I'm pretty, not super anxious for the most part. But, then when we met and you were like, I think you might actually benefit from this, and met with Serena, and I was just like, do it, put it in yesterday. Like, I don't care if it gives me any little chance of, and again, the chance of it happening may never happen, hopefully. But if there's any little chance that it could potentially save my life or help me in some way, then I'm happy to have it done, so.
The other thing, and maybe Dr. Itchhaporia can comment on this, when you came to me, you were doing EECP. And so I would say that's not necessarily part of our gold standard therapies for congestive heart failure or patients with cardiomyopathy, but I think there's been kind of interesting data that's come and gone in our medical literature. And so perhaps, I don't know if I'm putting you on the spot, Maya.
No, I agree. I don't think that would be the therapy that we would go to, and especially now with the quadruple therapy that Dr. Wright talked about earlier, I think patients we're seeing remarkable change in how the quality of life, the improvement of the ejection fraction, how the patients are doing. So I think that the therapy for heart failure has really evolved, and there are definitely newer, more well-established therapies that we have to think about rather than EECP, for example. I think there are end-stage patients with heart failure that may have benefited from that, but I certainly think nowadays, in 2023, with the therapies we have, there's a very limited role for things such those therapies.
I think the reason that I went to Cedars and they put me in the EECP, which, if you don't know what that is, it's a blood pressure cuff on your legs, on both legs, and it's basically pushing the blood up into your heart, and it's supposed to revascularize the heart. And I had been having chest pain as well. They were worried that I had some microvessel damage from the cardiomyopathy. So I was having chest pain, my blood pressure was dropping, was lightheaded, dizzy. So that was part of their program. And quite honestly, I actually feel like it made a difference. I think I did the EECP, and I went from having like chest pain randomly, almost on a daily basis, to I very rarely have chest pain. So, again, whether it works or not, I don't know, but it did make a difference with me to where it actually was valuable. So.
Great. Do we have any questions from the audience?
Tricia, thank you so much for sharing your story. That was great. I was wondering if you can go into a little more detail. You mentioned it a little bit, Dipti, about why she had that drop again in her EF. Do we think it's just because the meds were stopped? I mean, how often do we see what you call the rebound effect? And do we think there's another underlying etiology to her cardiomyopathy that caused her to have her EF drop again as opposed to peripartum?
I don't know. I would say that it probably was a rebound. I mean, I do think a certain percentage of those, when they stop their medications, you see that, and that's really the reason for the recommendation. I see Dr. Wright's itching to say something.
Yeah. So the reason is that obviously peripartum cardiomyopathy does not occur in a vacuum. There's a reason it occurs. For the majority of American women, it's because they have a genetic propensity. And so if you genotype these people with the standard cardiomyopathy gene testing that we do, you'll find that the majority of American women with peripartum cardiomyopathy actually have a protein genetic mutation that makes them vulnerable to having cardiomyopathy. Now, why it occurs right after pregnancy is not known. In peripartum cardiomyopathy is very common in parts of Africa. In some parts of Africa, 1 or 2% of all women get peripartum cardiomyopathy. And that may be nutritional, but in America, it's, in many cases, it's genetic. So if you have a genetic predisposition toward cardiomyopathy, it will at some point in most people manifest. It may not manifest until you're older, right? Which is why, as Dr. Itchhaporia said, once identified, then basically it's a commitment to lifetime medical therapy, which alters the natural history of the disease.
And along that point, so what happens in that group that does recover their EF, that does want to get pregnant again? So then what do you do with meds at that point, since you can't use Entresto or?
So can I just say that I would say, and I'll see what you think, Rich, too, but I think that we counsel them that 50% of patients have a recurrence of their cardiomyopathy. So I think a majority of us, dissuade them, particularly depending on how bad their cardiomyopathy was and what their symptomatology was. So I have discouraged patients that have had severe cardiomyopathy from not going through a second pregnancy. But again, ultimately the choice is the patient, so you have to provide them that. And I will tell you, there have been several patients that I did counsel and they still went on to have pregnancy. And you have to take them off those medications, obviously. And then again, there's a very high risk of them having recurrence, so you have to follow them very, very closely.
Yeah, the standard dictum is just what Dr. Itchhaporia said, which is don't get pregnant again. Now, most of those data come from an era before we had modern therapy. So, for example, if you said, what's the risk of being on an SGLT2 inhibitor during pregnancy? I actually don't know the answer to that. The answer that Dr. Itchhaporia gave is the one we normally say, which is we don't know that these drugs are safe during pregnancy or breastfeeding and therefore stop the medicines. Maybe that's incorrect. But I think in somebody that has a potentially life-threatening disease with pregnancy, the right thing to say is please don't get pregnant again.
And this could be a good question for Jodine. I'm sorry if I'm cutting anybody else off. But, you know, in terms of some of the dialogue that we as medical practitioners have with our patients, there are a lot of situations where we may say to them, these are things that will put you at risk, and they say, well, I'm getting pregnant anyway. So what are some of those kind of conversations, difficult conversations that like the obstetrical world has with their patients, and or how do you combat for that as they're going through the course of their pregnancy?
So I won't be able to speak too much as to before the pregnancy, but obviously those are very difficult questions, and we know ultimately, like you said, it's up to the patient. If she wants to get pregnant again, she's going to get pregnant again, and when she comes into the inpatient side, that's something that we're going to account for. So that's where we have those planning meetings, our interprofessional, multidisciplinary meetings where we discuss what medications is this patient on, what can she have, how much fluid can she have, what sort of delivery can she have, is she even a candidate for anesthesia. You know, I've had congestive heart failure patients that have not been a candidate for an epidural because of the need for the fluid bolus to prevent a drop in her blood pressure. So it's difficult conversations. Not only, you know, we suggest that you don't get pregnant, but if you do, you may not have the pregnancy and the delivery that you're really envisioning, and that's another blow to your patient that they're going to have to deal with, and the nursing staff and the OBGYN staff are going to have to plan for. It's a lot of planning, a lot of meetings, a lot of discussions, a lot of overtime.
You know, I'll also say that I think that the conversation is not had one time but multiple times with that individual. And typically, if you're seeing the patient alone, I always encourage the family members to be there, including a spouse, because cardiomyopathy is not an isolated issue. The family is involved in the care of that patient. So the family needs to understand what that person is saying, that there is a chance of having a recurrence and that they could get quite sick or may even die potentially, depending on how bad their EF gets. So that is, and sometimes when you have those conversations multiple times, there seems to be a little bit better understanding, because again, it's not enough to say the patient chooses. Ultimately, does the patient really understand what that means and what they're choosing?
I could keep going. Yeah. So as you were doing your talk, I was realizing that my talk is your story. And so a lot of the secrets of things that you have in terms of your history, we can maybe talk about some of the rheumatologic stuff and, you know, how that may overlap. I don't know if kind of the peanut gallery would have some input, but maybe we can talk about because you're on certain medications for autoimmune.
So prior to this, I mean, I was, we could say, pretty healthy, but I had a lot of rheumatological things start happening to me in my early 30s. Randomly broke my back riding a horse, didn't fall off, just galloping, know how to ride a horse, 4 compression fractures. Bilateral carpal tunnel I had repaired. Suddenly my rotator cuff tore on my right side of my shoulder while I was in the ER. Actually, all these things started happening when I started working in the ER.
St. John's, huh?
In 2001. So I was young, you know, whatever, and then got married and then tried to have kids and then determined I couldn't have children because I had an underlying fallopian tube dysfunction. So I had all these weird inflammatory things going on, not really knowing how it all fit together. Had to do IVF to have my kids, got my son, then started to have really a lot of like joint pain, arm pain. Then they determined that I might have like a mixed connective tissue, couldn't determine exactly what it was. Didn't really go on any medications, got pregnant with my daughter, but then after having her and after the cardiomyopathy, really started to have joint pain, all of it. And so then I ended up going to rheumatological, like really deep diving into that. And then they started me on Plaquenil, which is for like a rheumatological inflammatory disorder. that didn't really control it, and then they actually put me on methotrexate, which is another, medication for rheumatological stuff. And then finally things kind of got better. So it was always interesting for me to think or understand or, sit down and figure out why is there this underlying autoimmune factor that had a play in all of this. And then recently I had genetic testing done with you guys. And so, Dr. Wright, I'm expecting a full analysis of what you, can come up with my history. And I just had the genetic testing, and then Nicole just called me like a week or two ago saying, oh, well, it's interesting. You have this, gene mutation for a prolonged QT syndrome. And I'm like, huh? And so then we're going to go back to Dr. Wright, who can sum it all up for us and make it make sense. So yes, I am that person. I have some weird autoimmune underlying issue that, maybe in conjunction with my genetic mutation was the predetermining factor for my heart issue, so. But I don't know, so you tell me.
It is a lot, and I guess so it was a prolonged QT.
Yeah.
And I called Serena right away, and I said, she has an AICD, so we're cool, right? And so Serena said, yep. That's good. And then I had a little dialogue with Rich, and he said...
So that's why you had peripartum cardiomyopathy. That's why you had it. Like I said, everybody with peripartum cardiomyopathy needs to have genotyping. And depending on what city you're in, 1/3 to 2/3 will come back. And the reason that's relevant is partly to determine what medicines are best for you, partly for genetic counseling purposes, right? Because it means your first-degree relatives, if you have any siblings, parents, and your children might also have this propensity, and that will be useful perhaps in counseling those people. The state of the art right now is that we don't typically use genetic typing to determine medications yet. There are a few mutations that are known to be more noxious, and that might influence choice of defibrillator, for example. And maybe in the near future, gene replacement therapy, and there are the first few cases where gene splicing has been undertaken to cure cardiomyopathies in people. So that's an option. But one thing that Nicole said and that you said, and that is that we test, when we do gene testing, we test 92 genes that are the most common, and there are over 1,000 mutations in those 92 genes that lead to heart failure. Okay? Now, some of those genes typically lead to an arrhythmia potential, as was just stated, QT prolongation, but the Venn diagrams for these all overlap. So you can have a mutation that is typically associated with hypertrophic cardiomyopathy, but actually presents as dilated cardiomyopathy, and vice versa. You can have what looks like QT prolongation, but actually presents with dilated. That's what you have. So, and it wasn't manifest in your EKG. You already told us that your EKGs were normal. The manifestation you had of this protein abnormality was dilated cardiomyopathy. And as I said, that is why you had it. I don't know if the rheumatologic things had any influence on this at all. Usually when we look at rheumatologic things, it's the inflammatory coronary disease aspect of things that you heard about from Nicole and other speakers.
Any other questions from the audience?
I could keep going if you want me to. I can keep going. Jodine. Hello. So I talked about the microbiome during my talk, and I feel like it's a little fluffy. But in terms of some of the literature, and I'm not 100% sure that I tortured you with my talk, but we talked about the vaginal microbiome and some infectious issues and inflammatory states that are related to that. And I don't know if you could maybe speak to some of your experience within the obstetrical world in terms of infectious issues, delivery, early labor that go on with that, and or what are some of the ways that you all combat that in the world of obstetrics?
For an infection specifically?
Yeah, for like imbalance in the microbiome, separate from necessarily a peripartum cardiomyopathies.
So on the inpatient side, infection is something that you're going to be looking at as a reason for some of your preterm labor and preterm delivery. Ways that we combat that would be, if we haven't done all of our testing yet for like group beta strep, for example, making sure that the water doesn't break, and we stay vigilant to make sure that the water doesn't break if that's something that we can not have happen. And there are certain there are certain procedures that we can do, for example, like cerclage placement for preterm labor, things like that. Antibiotics are one of our orders that we would give for preterm labor and preterm delivery as standard. So that's typically our plan of care when it comes to microbiome issues.
Because obviously keeping the baby inside,
keep baby
is generally
in
a good thing
and
until it's the end. Yes.
contained with their fluid.
Anyone else?
If I can, one of the things I would like to add is that, when we watch Trisha's story and we see that, she had preeclampsia and, one of the things I was saying, when we're listening to Trisha's story and we see that she had preeclampsia and she had that drop in her blood pressure on the OR table, and you had that feeling of impending doom, and then you go home and you've got shortness of breath. That's really why we're looking at our discharge instructions and our discharge education with our doctors and our postpartum nurses. A drop in blood pressure on the OR table is not uncommon. It's one of the side effects of spinal anesthesia. So that wouldn't have been a red flag for us. Her swelling that she had, that's one of our signs and symptoms of preeclampsia, so that wouldn't have been a sign for us. And we know that gets worse before it gets better after delivery. Shortness of breath, however, a lot of patients might think, oh, I've just had a baby, I'm recovering from surgery, that might be normal, but it's not. And that's something that we strive really hard to explain to our patients when we're doing our discharge teaching. This is what's normal, and this is what's not. This is when you need to call your doctor, and this is when you need to call 911.
All right. Well, I would I'd like to thank all of our panelists, but particularly Dipti and particularly Trisha. We've in the course of the day gone from a very universal to a very individual place with tremendous overlap, where all of the themes that we heard about in the morning really play out in a very powerful way, and I think it's come together very nicely, just as we have as a group, and so thank you to everybody.
So we are honored today to have Lana Negrete here with us. She's the Mayor Pro Tem of Santa Monica and an advocate for women's heart health awareness. She's devoted herself to the Santa Monica community for years. She's experienced every major milestone here. She's attended Santa Monica High School. She got married at St. Monica's. She lives here with her husband and 2 children. She serves as a member of the City Council. She's founded an organization called Outreach Through the Arts and is the owner of the business, the Santa Monica Music Center, which provides access to many people in our community. She's an elected board member of the National Association of Music Merchants and passionate about education. She was the legislative representative for the Santa Monica PTA and Council, advocating for our youth and public school education at the state's capital, and she serves as an advocate at the federal level to ensure music and arts education is fundamental and a funded part of our public schools. With respect to health, she's working to create and advocate for a more inclusive healthcare experience, one that allows women across all socioeconomic backgrounds to get the education and comprehensive care they need. And she's passionate about creating that space, just as we are with providing all the material from today online, free access for anyone who's interested. So she's here with us with a special proclamation making February Women's Heart Health Month here in Santa Monica, which will be made official on Valentine's Day, February 14th at the City Council meeting. If everyone could help me to welcome Lana to the stage.
Wow, thank you so much for having me. Listening to these stories, I found so much connection in all of it. I'm on my own journey right now with my heart health and just my health in general as I'm 43. And I see somebody, familiar face. And so when I met Christiane, she brought this to my attention. I thought, oh my gosh, this speaks to me. I wasn't as aware that, heart health was the number one, I don't want to say killer for women because that doesn't sound so positive, but I have been educating myself these past 30 days and been talking to my mother a lot, who's actually watching online from Lake Arrowhead. And I really want to be an advocate and be a big supporter. And I wanted to make sure that our community was aware about women's heart health and all the things that all these beautiful people in this room are doing to educate people. So thank you for all the doctors and everybody here who's put this together. And I want to read this proclamation from the city of Santa Monica. So, whereas Have a Heart, Save a Heart is a nonprofit foundation established in Santa Monica whose mission is to raise awareness about women's heart health disease by employing cutting-edge technology, hosting creative education symposiums, and encouraging community participation in health and wellness programs. And whereas, according to the Centers for Disease Control, heart disease is the leading cause of death for women in the United States, killing over 300,000 women in 2020, about 1 in every 5 female deaths. Despite increase in awareness over the past decades, only about half, 56% of women recognize that heart disease is their number one killer. Sorry. And whereas cardiovascular disease is increasing nationwide in working age adults, particularly among Black adults, in addition, 1 in 16 women aged 20 and older have coronary heart disease, the most common type of heart disease. And February is nationally recognized as American Heart Month, a time when all people can focus on their cardiovascular health. And whereas Have a Heart, Save a Heart is hosting its 10th annual Women's Heart Symposium on February 4th, 2023, which aims to raise awareness and provide information on women's heart disease, risk prevention, healthy lifestyle habits, medical advances, and more. Therefore, the Mayor Gleam Davis, myself, Mayor Pro Tem, and the entire City Council and City of Santa Monica, on behalf of all the members of Council, do hereby proclaim the month of February 2023 as Women's Heart Health Month. I don't know if someone wants to receive or take a photo, but again, thank you so much for all you do. I'm looking forward to sharing all of the education opportunities for our community to become more aware, and also for those of us in the community that need to contribute to support these efforts to educate everyone. Thank you so much.
Well, we have a little presentation. As many of you are well aware, we are a charity that supports other charities. In the past, we have donated to Heartfelt, which is an organization that screens young athletes for cardiovascular disease before it's too late. Camp del Corazon is another charity close to our hearts that the famous Nikki, as well as the late Dr. Cabine, used to sit on the board for. The charity gifts kids with congenital cardiovascular disease a camp experience at Catalina Island that is unlike no other. We have also supported the Open Hearts Foundation, which has programming to help women and children throughout the globe. And most recently, we have given to Project Angel Food, which prepares and delivers healthy meals to feed people impacted by serious disease, bringing comfort and hope every day. This past summer, when a grant that they had to supply meals to congestive heart failure patients in need throughout the Los Angeles community ran out, we were able to donate, and they were able to continue their programming to keep these people healthy and out of the hospital. Project Angel Food is a wonderful organization, and we are excited to be able to make another donation to them today. Can we please have Mark and Marjorie come up to the stage?
Hi, everybody. We're very excited to be here. I'm Mark McBride, the Director of Philanthropy for Project Angel Food. And some of you may know about us. We've been around for about 34 years, founded by Marianne Williamson in 1989 at the height of the AIDS epidemic. And today we serve 2,600 people a day. 737 of them are people living with heart challenges. And of those, 50% of those 737 people are women. So I'm really excited to bring Marjorie, who's one of our clients. We met in the car today. And Marjorie was a nurse's aide in her work life and is now a client. And the miracle is that her daughter was born in Kansas City, Kansas, at a hospital near where I was born. We find out in the car. So what you learn in this work is that the world is this big. And everything you do, whether you work for a pharmaceutical company or whether you're a nurse or whether you're a doctor or whether you're a patient or a client, we're all in this work together. And so I'm personally extremely grateful to get to do the work that I do to raise the money we do and to serve people like Marjorie. Marjorie, you want to say hi real quick?
Yes.
Say hi.
I would just like to say that I have been a recipient of Project Angel Food for 8 years. It has been a blessing to me. See, I have congestive heart failure. And it's been kind of hard. You know, things is hard. You can't do all the things that you used to do. But like I said, with Project Angel Food bringing me my meals, it's been really good. And I just feel blessed. And I thank all of you guys for your donations and the things that you guys have done to keep Project Angel Food running. Because I'm one of those. So thank you so much.
So Have a Heart made a gift to Project Angel Food last year of $10,000, and that gift provided meals for 1,000 of our clients. And so there's another gift today, which is we're the beneficiary of all of this from you, and we just want you to keep doing the work that you're doing to look after folks like Marjorie and the work that we do, and we're incredibly appreciative to all of you. Thank you. Oh.
We are so proud to partner with Project Angel Food to present them with a check so they are able to supply even more healthy meals to our community. You want to do it? Why don't you guys, you guys can come up and do the thing. Oh. So today's event was a culmination of a full year of preparation and 10 years of your support. This is a mission that we quite literally cannot do alone. We want to thank everyone who made today possible, our volunteers, the event staff, our exhibitors, our raffle donors, our AV team, Hotel Casa del Mar. We would like to give a special thanks to some of our very special donors, the Speed family, the Davidsons, Honorable Susan Bryant Deason, and Mr. Paul E. Deason, Tamara Rowett, Barbara Bowman, and every person who gave a single penny to our cause. We thank you so much for your participation. We thank you for your energy. We thank you for your support. And when we say it, we mean it from the bottom of our hearts. Until next year.